nights. Lean against the wall at a Blondie tribute concert. We had that same old talk in the car. On the way over, I said I love him. I said
Bore da pawb, croeso. We're being joined by a virtual audience as well, so we need to start on time, and I'll come back to a few words on that. Well, I think it's September 2019 since I was last at one of these, and I've just forgotten, and I've just reminded myself the housekeeping. There are no fire drills. If the alarm goes, then the fire exits are there, and at the end, and you muster just outside the building. We have simultaneous translation. You will have a headset on your chair. It's a simple on-off switch wheel at the bottom, and if you, I am asked it by the translators if you could not put them on the floor and tread on them inadvertently. And for the virtual audience joining us, I think there's just under 100 people joining us virtually. You can also get translation if you need, and I have to do this from memory now. If you want to hear a translation, if you hover on your Zoom screen, you'll see a world at the bottom, and when you click on that, you'll have the choice of keeping original language or hear translation. So if you need translation through the event, then just click on hear translation and leave it at that selection, and you'll then hear an English translation feed if you need it when anyone is contributing in Welsh. We have an opportunity at the end with a panel session for everyone to get involved in questions and discussion, and that includes those people who are joining us virtually. Use the facility on the Zoom screen to write your question, and I will see it on the screen here. And as well, please do, if you wish, use Welsh to write your question, because the translators will translate that for me, because I'm linguistically inadequate. Just by way of introduction, very briefly, before I invite the first speaker, it was occurring to me the weekend after next, I'm rather stupidly volunteered to lay a floor for my daughter and son-in-law, who live in a tiny house in Surrey. So they're having to move out with their 2 children whilst I move in to do the work. And they said, well, Dad, if you want to watch the television, you're going to have to download an app. Okay? If it's chilly and you want to stay warm, you're going to have to download another app. And if you actually want to be in the light when it gets dark, you're going to have to download a third app. I think the fact that we've joined the digital revolution, we all know, and increasingly day by day, our lives are going to be not controlled, but us able to control our lives much more through digital applications, digital interface. In health, it's a bit like an iceberg. There's a huge amount already going on in use of digital applications that patients and citizens won't see, because to date most of that has been directed at and for clinicians of all types and varieties, using digital applications to support their patients in a whole range of different ways, through bookings, through your x-rays, through your tests, nurses taking records. There's a huge amount going on, but that's going to become a whole lot more visible over the next months, the coming year, 18 months, as the new NHS Wales app is developed and the new e-prescribing systems are developed. People are going to see the opportunity for digital engagement with their services and with their own managing their own care much more. Dr. Julian, and people may well have heard this analogy, Dr. Julian Tudor-Hart, probably no more than 30 miles away from here, as a GP in a Valleys community, developed the concept of the inverse care law, where those people, his patients who needed care most, had worse access to that care. And here we are, I think it's something like 70 years later, needing to be very careful that as we develop digital systems, digital applications, we don't have technological Tudor Hart inverse care law, so that those people who need access to services and consume more health and care services than others are in some way worse off than they might otherwise have been. And what I think I'm very keen to do in my short period in this role, working with many others, and this is why we've brought people here together and doing this, co-sponsoring this with Compass and WCVA, is that we actually make in Wales an intended consequence of inclusion rather than an unintended consequence of exclusion. I think it's really important that we focus on that, and it's also really important that us in the statutory public services in health and in care understand the really important role that the voluntary sector, the community sector have in helping us ensure that intended consequence, because the relationships that you all have with people, groups of people who might be excluded were we not to take appropriate action, is going to be critical for us delivering inclusive digital systems into the future, particularly those that are citizen and patient facing. So it's a really important day for us in DHCW, working with our colleague organisations, Compass and WCVA, and I'm pleased that we've brought together a group of speakers who are going to cover a range of issues, and in the first block before our break at around about 11, just after 11, I think we're going to hear some of the challenges. I suspect in the first contribution we're also going to be challenged. We're going to hear about the role of digital in developing health systems, the developing concepts of health around value-based care. Then we're going to hear about the next step change that we're undertaking, that we're part of, which is the NHS Wales app. And finally, importantly, we're going to look at the role of digital in service design and delivery, with a number of practical examples of it in action. So I'm not going to take up any more time, but invite Helena Herklotz, who's very kindly agreed to give our keynote address, the Older People's Commissioner for Wales. Helena.
Thank you very much, Giacomo. Good morning, everyone. It is lovely to be with you in person. I don't know about you, I still get awfully excited when I'm actually in person. So for those of you joining online, it's lovely to be with you as well. One of the things I find interesting coming out of this sort of online world is you don't know how tall people are, do you? And you kind of imagine how people are, and then you see them in the flesh, and it's sometimes quite surprising. But first of all, I want to just say a huge thank you for inviting me today, and also congratulations on the conference ahead. Looking at the programme, I can see you're covering a huge range of issues, and I would very much commend Digital Health and Care Wales for bringing together different organisations to come together and to think about, from my perspective, how we can ensure inclusion in a digital age. So I'm going to cover a little bit about my take on this as Older People's Commissioner for Wales. So obviously I have a particular interest in everyone over the age of 60, which is what my remit covers. But hopefully some of the things I say that are challenges for the older population will resonate in terms of challenges for others in society, particularly maybe those with disabilities, those who are facing pressures in terms of cost of living, and those in rural communities and minority ethnic communities, for example. So along the way, I'm going to draw some important cultural references. One is to the film Ghostbusters. One is to the children's television programme Bob the Builder. And I may, if I'm brave, talk about a rather dodgy advert for lager back in the 1970s or 80s, I think, and draw an analogy with the voluntary sector. So points will be awarded for guessing what those are as they come along. So I want to start really by talking about how this fits into my work. So as Commissioner, I have 4 big priorities that I'm working on with me and my team. And I want to draw really a comparison with some of these issues and what you're going to be covering today. And first of those is about protecting and promoting older people's rights. And I'm going to talk about the rights that we all have and the rights that older people have under the Human Rights Act and the European Convention on Human Rights to access information. Because that is a key right that people have that we need to make sure we don't disregard as we develop more digital services and information. Another key area of my work is about how we can stop the abuse of older people. And one of the areas actually where there is increasing abuse is online. All sorts of ways in which people might be facing losing money, being scammed, romance scams and everything else. And this is an issue in terms of barriers to people getting online. It relates to fear and it relates to confidence. Ending ageism and age discrimination, probably ageism, which is about the prejudice we have towards people of other ages. The World Health Organization assesses that 1 in 2 people worldwide, 1 in 2, hold ageist views against older people. That's about how we think and feel and act towards older people. So we need to be sure in all the developments we make that we're not doing that with any ageism or age discrimination in play, and we have to challenge ourselves on that. And finally, enabling everyone to age well. So digital and technology can improve our lives and do improve our lives. And we need to enable this to really help us all age well. And there's a lovely phrase that I use a few times on this, which is it's not just about adding years to our life, it's about adding life to our years. So how can we use all the great good practice here in Wales, all the technology, all the new digital developments to really add life to our years? But I'm going to talk about some of the challenges to start, and I'm going to talk about digital exclusion. So on this chart here, you can see three blocks. These are people over 75, 65 to 74, and 45 to 64. And the blue bar shows those without access to the internet at home. The orange, those who do not use the internet. And the grey is those who haven't accomplished 5 digital skills. So what it shows for the over 75s, just over 30% have no access to the internet and do not use the internet. So just for a moment, let's think about that population. It's about just over 300,000 people over 75 in Wales. And what do we know about that population, as well as being digitally excluded? More likely to have long-standing illnesses, more likely to be living alone, and more likely to be in poverty. So to the earlier point about the inverse care law, there's a very real risk that some of the people that the NHS and social care most support are going to find some of these challenges most difficult. But also, as you go down that age span and get to the 45 to 64s, we cannot assume that everyone coming through is going to be connected. So I'm in that 45 to 64 bracket. I guess quite a few of us in the room might be, but quite a few of us haven't necessarily accomplished 5 digital skills within the last 3 months. And those skills are things like accessing information, uploading an app, posting on social media, transacting, buying something online, for example. So it's not just about people who are not connected, it's about confidence and use and ongoing support. So this issue of how we help people who are digitally excluded is not a short-term issue. It's not just about helping the over 75s. It's something we will all need. So for me, most of the way in which I keep up with my digital skills is because I'm working. And I guess that's probably true of quite a lot of us. So when we stop work and technology is moving on apace, how do we do that? Who do we turn to? Who is there to help? So it was because of my concerns about older people being excluded in many different ways that I've issued formal guidance to health boards and local authorities. So as Older People's Commissioner, I have a number of legal powers, and one of those is to issue guidance which public bodies must give due regard to and report to me on what they're doing. And older people were telling me that it was increasingly difficult to access public services because they were not online or they weren't confident about using the different types of technology they needed to do. And as we go forward in a digital world, we have to make sure that we leave no one behind. And that's a lot of my focus around digital development. So I'm going to talk a little bit about the guidance that we produced and what we've done. And just to let you know that later this week, and I should know which day it is by now because there's only about 3 days to go in this week, so it's either Thursday or Friday, we will be publishing the report, the summary of responses that I had from local authorities and health boards on all the good practice they are doing on getting people online, on all the good practice they are doing on helping people who are not online still to access information and services, but of course putting some pointers ahead to what more needs to be done. So this guidance ensuring access to information and services in a digital age was developed working with older people and stakeholders, so drawing on what we knew and what was happening. And one of the key things it sets out is what our rights are as citizens, and it's worth just saying what this is. So we have a right to access information, which is part of our broader right to freedom of expression, and therefore is actually protected across several human rights instruments, including the European Convention of Human Rights and the Human Rights Act. So this is a right that we have to access information and communicate in a way that works for us. So we can't be in a position where people aren't able to do that, because then their rights would not be upheld. So the guidance that I issued was to say that any move to digital services must be accompanied by measures to ensure that the human rights of older people are protected and that they are enabled to access information and get to the services they need by offline channels, or should they choose, they're supported to gain the skills and confidence to be able to connect online. And what this guidance also did, and this is important, is illustrate good practice. So the two things I think here is one about sharing good practice, and this is a fantastic day to do it, and also having a focus on, as we move into an increasingly digital world, how do we support people who can't access that? And there are two things we need to do. One is to do all we can to help people get online, and there's some fantastic work going on, but we also need to make sure at the same time that we're enabling people to continue to get information and continue to get services if they cannot connect digitally. Sometimes hear about digital by default, but digital by default sometimes means that you're saying if you don't get online you're excluded, and we cannot allow that to happen. If we do, some of the most vulnerable people in our society will not be able to get the help that all of us want to make sure that they can get. And some of what's come through, I think, from this is the importance of frontline staff across our councils, our health, our NHS and our local authorities, helping people, supporting people to use technology, giving them confidence. The importance of giving devices to people, but also thinking about how can they afford to connect, so how can we make that happen. The importance of staff training, and some of what health boards and local authorities have been saying to me is subsequent to the guidance, they're now looking at staff training in relation to this, and also at their equality plans, because this is an issue of equality as well. So I'm going to be continuing to engage with older people, and one of the pieces of work I've also done is just produce a guide for older people on knowing their rights. So generally, if I'm doing a piece of work, I will also think all the time about how can I make sure that older people know their rights. So if you're working with older people and you want them to be clear about what their rights are in relation to accessing information services, we of course have hard copies of these, but you can also get them from our website as well. And as I said, the report will be coming out later this week, and I'd encourage you to look at it, to see the good work that's going on, to see what organisations and health boards and local authorities are doing, to look at some of that good practice, but also to check, to remind ourselves what more needs to be done as we go forward. So I want to talk now, just in conclusion really, about some of the sort of key messages, I guess, for your day ahead. And first of those is just to recognise the unbelievably challenging context within which we are all working and living at the moment. I'm almost struggling to find the words to describe what is happening right now. So all public services, all voluntary organisations, you are all under immense pressure. Workforce pressures, cost of living pressures. You all have that in common. Many of our citizens are struggling right now. And for older people who have somehow with your help got through the last 2 or 3 years, now facing an incredibly scary winter. And I want to just give you one example of how that feels. I was talking to someone whose daughter is a home care worker. And a couple of months ago, she was visiting older people, and she noticed that the older people that she was visiting had very little food in their fridges. Now when she visits, there is no food in the fridge, and the fridge is turned off at the wall. And it's still only September. So the cost of living crisis and people struggling just to survive is, I'm afraid, the context within which we're trying to do this stuff. And I think we just have to be honest about how difficult that is, that when we're trying to engage people, just what they're dealing with, and of course just what all of us are dealing with as well. And for voluntary organisations, they're dealing with those cost of living pressures in terms of the bills going up, they're dealing with those workforce challenges, but many of them are also struggling to raise money as well right now. So for those of you working in health boards and local authorities, voluntary organisations are under a lot of pressure too. So how we work in partnership, how we think about how we can use our scarce resource to support each other is really important. But in the words of Bob the Builder, can we do this? Yes, we can. But we're going to have to really work hard together. And I think it's important that we're honest about the challenge. And it's important that we monitor very carefully what's happening. So one of the things I will be looking at when the app is rolled out and as digital services develop and are rolled out, I won't particularly be looking at the take-up data, although that's important. I'll be looking at who isn't taking it up and who isn't using it. And I'll want to see the age breakdown of that, and I'll want to see the protected characteristics breakdown of that. Because if we collectively fail the people who most need our support, then actually we're not doing what we need to do. So that's going to be incredibly important, but we need to be honest about the challenges that we face together. The second thing I want to say is just about putting ourselves in people's shoes. So I want you to think about Mary Jones, who is 82 and lives on her own. And for many years, she was caring for her husband, who had dementia, who died last year. She's not online. So how does she know about the changes that are being made to the services that she needs? How does she get that information? Who can she ask? Who can she trust to give her that information? And if she's thinking about getting online and getting that support, what does she do if something goes wrong? So just to ask you a question, can you put your hand up? And you have to do this at home or in the office where you are online. Put your hand up if you've had an IT issue or something go wrong with a smartphone or computer or downloading. Can you put your hand up if you've always been able to sort that out on your own? Okay, there are 2 people. Can I ask you what your name is? Lowry. John. Okay. If you could share your contact details later. If any of us have any problems in the future, we go to Lowry and John. But for most of us, we need someone to help, don't we? But if you're on your own, and maybe you've had one lesson or one person to kind of help you set up, where do you go? So we need that ongoing support. We need that digital buddy, that person we can trust who doesn't make us feel stupid. It's not because we're old that we can't do this. It's because we grew up in an entirely different time. Do you know, older people have coped with the most change. But we just need to get alongside and help our fellow citizens to do that. So we need to make sure that people have got someone that they can call. So Ghostbusters, who are you going to call? There we go. So those organisations, Compass and others, and voluntary organisations and people that can help, give people someone that they can call and trust and manage it. Because otherwise you're going to do one thing with them and people will lose confidence and not go back. They won't go back to it and you'll face a bigger barrier. The third thing is about knowing your partners. For many years, I worked in the voluntary and charitable sector, and one of the things we spent a lot of time doing is working out what the structures of the NHS and local authorities were so that we could work with them, because it was really complicated if you're not in it. To those of you in the statutory sector, you need to do the same for voluntary organisations. So think about the partners, think about their pressures. Sometimes I hear voluntary organisations say to me, do you know, when we get approached by governments or statutory bodies, sometimes it feels as if they think we're kind of sitting around waiting for them to come and say, can we have some of your volunteers? And that we're suddenly ready with an inexhaustible supply of volunteers. It's not like that. There are no free goods. Volunteering costs money. You need training and support. You need recruitment. All of that. So it's just about recognising those different pressures and understanding and really coming together in partnership as equal partners, that people have got different skills, different responsibilities, but equal partners. The next thing is about that good practice. And, you know, I think we're doing fantastic work here. So it is unbelievably challenging. But if you look at how far we've come, if you look at the speed with which you change things, you work together during the pandemic, we need that going into this winter again. We need that spirit of togetherness, putting the citizen first, doing things we didn't think we could do, and involving and including those we are working with. So there's a mantra that many trainers use, which I think is really good, and it's one to remember, I think. It's this: if you tell me, I forget. If you show me, I remember. If you involve me, I understand. So we can't just do the telling. We must at least do the showing. And for so much of this, we really need to involve so we understand and can work together. And my last couple of comments is really about not disadvantaging those who are not online, or who are lacking confidence, or simply can't afford to have a smartphone or have the data that you need. And not just thinking about the services that you're directly providing, but thinking about the user journey. So if people are coming to the hospital, if the only way to pay for parking is on an app, you're potentially excluding people on that route. And voluntary organisations can really work with you to reach those people. So community connectors, those sorts of roles are incredibly important. And here's where the dodgy analogy to a dodgy advert back in, I think, the 1970s or 1980s, which was for Heineken Lager. Can anyone remember that? So on reflection, I think this is a really dodgy advert. But Heineken Lager apparently was the beer that could reach other parts that other beers didn't reach, which when I thought about it, I didn't even want to think about it. But it's about working with all those organisations that can reach the parts that you can't reach. Yeah? We've all got a role to play, but it's thinking through, it's working with communities, it's getting alongside communities. If you can't connect with people, think about the people that can. And finally, I just wanted to say kind of the importance, really, of digital health and care Wales and the importance of today's conference. So I think it's terrific. The approach that you're taking is by working in partnership from the off, by listening, by getting alongside. This is something that we can do. We can really embrace and use digital for good. In terms of my role as Older People's Commissioner, this is what I'm about. I'm working for a Wales where older people are valued, rights are upheld, and no one is left behind. And I think if we take that into our work together, we can achieve great things. So I wish you well for the conference today and for all your work. And thank you so much, Uwchgynhadledd, for inviting me to take part today. Thank you.
Thank you, Helena, for kicking off. And as I said, I suspected then we are challenged, and we need to rise to the challenges that you've highlighted. And it did remind me that I spent it was about 15 years, the unpaid consultant, IT consultant to my dad, and towards the end of his life with his iPad. I didn't know you could split a QWERTY board on an iPad until I had to fix it, but he was in a terrible state. So it resonated, that physical support for people to engage digitally as we hope people will. If we move then on to our next speaker, Sally Lewis, who's the Director of Welsh Value and Health Centre, but also very much involved in the work on a number of our key programmes. I won't say any more. Sally.
So hello everyone, Borodar. It's a pleasure to be here back in the Life Sciences Hub. So I'm going to pick up where Helena left off, really. Everyone in the room here, all of us working in health and care and all of us working in communities have this aim, I would suggest, that we want better outcomes for the population of Wales and we want to be in better health and have high levels of well-being in the community. And that's incredibly challenging at the moment, as has already been highlighted, because of the extraordinary situation we find ourselves in, emerging from the pandemic, cost of living crisis, and all of these external forces that are going to point us towards poorer health, not better health, and we can do nothing about it. So that leaves us in a position of moral distress, doesn't it, where we want to do the best that we possibly can, but there are all these things against us in doing that. And that's how I became involved in value-based healthcare. Because value is this. It is the equitable, sustainable and transparent use of available resources to achieve better outcomes and experiences for every person. So we do need to have a reality check. We are going to have a terrible squeeze on resources. People in the community are going to be struggling with the cost of living, and that's going to affect their health this winter. But there is something we can do about it, and that's what I'm going to talk about over the next 15 minutes or so. So value in health is not a new thing, and there are many movements around the world that tap into this notion that all has not been well in health and care for quite some time. In that, we have not involved patients and the public as much as we could do in the delivery of healthcare, either in designing services or in working with them in a therapeutic consultation, shared decision-making, understanding people's goals and preferences, and then tailoring care to meet their needs. We have not tackled the inverse care law. There is still huge inequity of access to healthcare and inequity of outcomes. And we don't always use our resources wisely. We don't do that on purpose, of course, but we don't necessarily direct resources to where they're going to have the greatest impact. And so, of course, we had prudent healthcare in Wales, which I always tease the Scots that predated their realistic medicine, and they actually copied us. They really did. So prudent healthcare talks about co-production, both in the therapeutic consultation, but also working with people to design services, so directly relevant to this digital inclusion agenda. It talks about equity, meeting the greatest need first, and it talks about taking waste out of the system as well. Slow medicine, my particular favourite from Italy, has been going the longest and really is all about building well-being in the community, and you can imagine how the Italians portray this. And I remember the speaker talking about this when I first heard about slow medicine, incredibly flamboyant gentleman talking about slow food and slow love and slow healthcare, and all of this. So, but it's all tapping into this notion, isn't it, that we need to be more than just healthcare and processes of care, that we need to build communities and build health and well-being and use our resources wisely. So we really are now in the eye of a perfect storm. And we've needed to change the way we deliver health and care for quite some time, really, for all of the reasons on this slide. But now that imperative has become even more urgent. So what I want to focus in on today is how custom and practice in healthcare takes us in the wrong direction sometimes, and how we have a lot of work to do with clinical and operational teams in healthcare organisations to do this right. So it's not just about the technology, it's about processes of care and people as much as anything else. So as we are in this perfect storm, each clinical specialty comes out with the perfect guidance for managing their patients. Of course they do. As a GP myself, I would, have a view around what was the perfect scenario of resources to meet the needs of my patients as they were in Ebbw and Tredegar. But that comes into conflict then with the resources that one of my colleagues might need somewhere else in Wales. So we have this plethora of guidance. We can't possibly do it all at once. We need to prioritise. And we can only do that if we work together, can't we? In co-production with the public and patients, honestly, but in co-production with each other as well, and sometimes ceding our wants to what may be a greater priority. And we must do that over winter, and we must do that as we develop the functionality that sits behind the NHS Wales app as well, so that it really starts to meet the greatest need first. The potential for inequity of access geographically and between patient groups. So the more powerful, high-volume specialties might attract more resources. That means potential for inequity of access for care or resources to less visible populations within Wales, for example. And that occurs geographically, and it occurs between patient groups, and it occurs in the digital space. So there's inequity everywhere we look, and we can only start to tackle that if we work together. The inverse care law was written about by Julian Tudor-Hart the day before I was born. So I'm not going to tell you how old I am, but you can probably guess it's, 50. So we have not tackled it, and in fact, the gap in healthy life expectancy in some parts of Wales is worse now than it was in 1971. Relative time sensitivity of interventions. So lots of people are waiting on waiting lists at the moment, but some of them are more urgent than others. Now, of course, we would want to not have a waiting list for anybody immediately, and this is going to be controversial, I'm afraid, to some of you perhaps, but I would suggest that we need to be brokering how we manage that wait so that we're really tackling those who are in greatest need first of all. Digital can help us with that. A growing number of people living with chronic conditions. So even if we had all of the money in the world, we do not have the staff or the buildings to deliver healthcare in the way that we always have. You pitch up at a GP, you have some tests, you go back to the GP, you get referred to a consultant, you see the consultant, you have tests, you go back to the consultant, and then you get followed up every 6 months until the end, or whatever the end of the episode is. We cannot work like that anymore. We've got too many people living with chronic disease, so we need to understand how we work with each other, so we know as people receiving care, how do we keep ourselves as healthy as possible, assuming we have the resources to do that. But this part about co-production is not just about doing to people, it's providing people with the information in the right way and the right support, not just to get online, but to manage their chronic conditions as well. And I see that as very much two sides of the same coin. It's a very similar issue. That failure to invest in supported self-management of people is very similar to the failure to invest in digital inclusion. Do you see what I mean? So we can bring those two things together, I think, and I'll come to that in a little while. And the reducing ratio of healthcare professionals to people needing care. I'm certainly a dinosaur. So in transforming healthcare processes, so I've just given you one example around a process of care referring from a GP to a consultant, we need to reimagine care. And that's really hard to do when you've been ingrained in a system, because the system does what the system's always done, and we've been in it for years, so we comply with that. But actually, what do people really need, and how do we deliver those needs, and what is technology as an enabler in that scenario? So what we're really trying to do is enhance a relationship, not replace a relationship, but enhance a relationship, and use digital communication appropriately to support those processes of care. It is never a replacement. So we might be able to do these tasks: appointment management and e-consulting. PROMs. So what are PROMs? Patient-reported outcome measures are a structured communication between people receiving care and their clinical teams that might give an indication of the burden of symptoms that somebody has on that given day. And that's really useful in guiding care, whether people need to be seen face to face. It's helpful for people to track their condition so they can compare how they are with how they were 6 months ago before they had treatment and so on. Access to and sharing of the medical records. So people need that information. They have a right to see their healthcare information, in my view. Access to clinical advice, flexible access to clinical advice. So we don't have this slightly arbitrary approach to follow-up where you get sent a follow-up appointment when you don't really need it and so on. That sharing of information can really help us integrate care. One of the mantras of healthcare over the last 20 years or so has been to improve integration in health and care, hasn't it? And we haven't really succeeded to do that at a system level yet either. So perhaps people receiving care and the public can integrate us by sharing their information around. Wouldn't that be radical? Self-management resources and chronic disease monitoring. But it takes two to tango. People can't manage their care on their own. It's a contact sport, literally. So there are some things people can do on their own. So let's say when we launch the NHS Wales app, we go into, I want to manage my exercise or my diet, you know, a bit like you do on your Fitbit. You might be able to do that on your own. But what we're talking about here is transformation of care and transformation of care processes. So to do that, we need the clinical teams as engaged, enthusiastic, supported and willing to make those changes in healthcare processes as much as we are with getting people skilled up in the community to use digital. So there is another form of digital inclusion which is pernicious and perhaps even more of a problem in that we will have inequity of access based on lack of ability of clinical teams to engage with that technology with their patients. Usually not because they don't want to do that, although sometimes that happens. Usually it's more to do with the fact that there hasn't been investment in the change management process for those care processes for them to have the headspace to do that, you know, because it's a change for them too. So how do we enable the tango to happen? That would be my question and my challenge to all of us, really, as we start to implement digital technologies. And at the heart of this is that therapeutic relationship, that special relationship between a person receiving care and their healthcare professional, whether it's their GP, whether it's their surgeon, whether it's their therapist, their nurse, whether it's their social worker, whoever it happens to be, their carer. And those relationships are what make us human. And boy, have we found that out over the last few years. So it's just amazing to be in a room with people. And if we damage that relationship, we will not get the outcomes that we want and need. And digital can't do that for us on its own. So it's a tool, and it must be there to support relational care, not replace it. And if we do that right, we will build people's trust in how we use their health data. Because clearly by interacting digitally with people, we will be gathering information from them, and people need to be really reassured that that's going to be used safely and sensibly and in the way that they would wish. And that's very much based on that relationship and the trust that is built. So finally, how do we enable that digital inclusion in the round? So it's more than just getting people skilled up digitally. How do we embed it in care and support that therapeutic relationship? So it needs to be supported as a service transformation programme, and that means altering structures within the health boards, within healthcare organisations. It means thinking very differently about how we do that so that we can really accelerate that change in healthcare. Troubleshooting for patients. So this is a really interesting one because I think there's different categories of troubleshooting. Where's Matt, who's coming next? Matt, the app doesn't work, what do I do? So where do I go for that? Where do I go for that help? But then there's the other part where, I don't know what to do because I've seen my blood test. How do I access some advice about my health care as a result of the technology that I'm interacting with? Matt can't answer that because that's not a technical problem, that's a health problem. So who tackles that and how? So troubleshooting is multifaceted in this space. The responsiveness and effectiveness of the care process. So if it doesn't support people's care, people won't use it. Why would you? So we have to make sure that we're responsive. Tackling unwarranted variation in access is really important. I feel very strongly about this. So how are we ensuring that equity between specialties? So it's not all about hospital care, but also primary care, mental health services. How do we tackle unwarranted variation between specialties, geographically, or between individual clinical teams? And how do we find out what's happening, and how do we track outcomes and evaluate the impact, and also track any potential inequities that may arise? And then, of course, to finish off, we must always accept that there will be some people who either do not want or cannot engage with technology-enabled care, and so we need specific in parallel approaches to tackle that, whether that's through enabling carers to support people, or having a completely non-digital approach for that growing smaller proportion of people who don't want to, and that's absolutely fine because it's about choice. So to summarise, this is all about preserving that therapeutic relationship. It's all about relationships, and the technology should be supporting that across the whole system of health and care. Thank you very much.
Thank you, Sally, for setting out some of the challenges that we've got as we develop think about services that could actually meet the needs of the nation as they grow ever greater. I'm going to ask now Matt Cornish, who already been billed, who's the Programme Director for the programme developing the NHS Wales app, as it will become known, I'm sure. Matt.
Thank you, Simon. Borodar, good morning, everybody. I'm delighted to be here to be able to talk to you about the NHS Wales app, but actually to talk to you more about what we're doing to ensure inclusivity and the work which we're doing in collaboration. Now, I've got to put quite a lot to pull together, haven't I? Because I've seen Ghostbusters name checked, we've had an element of tangoing, we've had Bob the Builder, and we've had Heineken, plus the element of therapeutic care and catching. So those pictures are really powerful. What I'll try to do actually is try to ground that into what we're doing and our particular approach. So I come here before you today, sort of 6 months in my tenure working on the programme, but the programme has been working for a lot longer than that. It's been working for 18 months, 2 years, 2 years of engagement with a whole series of groups and representatives of patients across Wales. I also come here having been most recently employed in healthcare management roles, both within Cardiff and Vale, where we are today, and within Aneurin and Bevan. So that's given me a connection particularly to those areas, but I've also looked after tertiary services across Wales, so I have a good understanding of need. In terms of the overview and a scope, I want to build on that theme of embracing the power of networks. Because that's where this programme is focused. We can't do that on our own, and so that'll be a theme which will run from the top of the presentation through to the end. Of course, we need to understand population needs, and we do that through our network, so I'll talk a bit more about that. Feedback at the heart of design. Actually, this is not just a technological programme that delivers and then, oh my goodness, we push it across the fence. Actually, at the heart of this, it's understanding those requirements and building on those requirements, testing to make sure that it works as is intended, and from a user perspective, it's achieving everything that they need, and then being prepared on a managed basis to be able to release. Sally picked up on this point. we can do so much technologically, but we're not solely in control in the way that products are received, and so we've got to work with others. And so I'll talk a bit about service transformation, particularly focused in the primary care area where a lot of the functionality or the early functionality in the NHS Wales app exists. We'll talk a little bit about proxy access and how you can improve inclusion and some of our current work. And then I'll go to where we need help from others, because we don't have all of the answers. We'll never have all of the answers, but that's where that kind of power of the network comes in. I should go back actually. They're not accidental, effectively, the screenshots on the side there. That's a representation of the NHS Wales app, which we're in pretty advanced stages of development. Our intention is to move this towards private beta next month. So people will get a real experience of being able to utilise the app, to be able to navigate through it, and the website as well, to be able to make sure that it's working for them and that the functionality is useful. Okay. Next slide. At the heart of this kind of hexagonal diagram is the Patients and Public Assurance Group. Now, DSPP, the programme, is unique in lots of ways in that the actual way in which we work is guided and assured by a whole series of different assurance groups, providing a different lens in what we're doing. Now, Patients and Public, as you can expect, is a really embracive group, open to all, which provides a view on the patient's perspective, the citizen's perspective on what we're doing. There are other groups as well. There's a practitioner group, there is a technical group, there is a service transformation group, a communications group. There's lots of different angles every month coming into the programme to help guide where we're going. And it serves a number of purposes, and that's sort of described in the hexagonal blocks there. Yep, partly to do with communication and feedback, both about the NHS Wales app and we're doing, but also feedback in keeping those particular networks alive and nourished with useful information which they can use. It's about engagement, of course it is, and bringing that expertise to place. And the key point which I picked up from kind of Harriet's presentation, we're not expecting standing armies of people out there who are ready at the drop of a hat. Actually, keeping people warm and alive to what the possibilities are is important in terms of their readiness to be able to support. And often, with a programme like ours, we don't know when it's their readiness to support. Actually, they're the people who tell us, so to speak, hey, we've got this, we're working in this area, this is what we could do together, which is really powerful. It's about the element of digital education and literacy. It's more than just about the data. It's more than about the device. We've all talked about it's how it's used and enabling people to be able to use it effectively. Ongoing support. This is not something to do with the NHS Wales app, which once we've launched, that's it. It's done. It's in a box. This is something which continues to evolve and develop as we improve functionality into the future. The aspects of co-production, co-design and co-creation are really important for us. We're not going to do this on our own. We want the NHS Wales app to land well, to be appreciated once we are able to be able to field it for people to be able to utilise. But our intention is that we will continue to develop it over time. Through the nature of our app, we've built this intelligent feedback mechanism into it, which we'll be trialling next month, so that people are going to be able to contribute their thoughts into how it's working for them. We'll be able to distill them and be able to utilise that to continue its development. And the last bit, I put a bit more on benefits and outcomes. We need to be able to understand, because of the importance of getting, I suppose, the end value to citizens, actually what it would mean for others to be able to support the app in its functionality. And I'm particularly talking about clinicians. So they need to understand the benefits of change so that they can then in turn provide those benefits on to others. Because it's not linear. Just because somebody turns on a switch doesn't mean that the service transformation processes beyond it are automatically going to be turned on and people are going to be able to receive those benefits. So there's a bit of work there to be done. I've put this slide, it's quite a busy slide, but it provides an illustration of the Patients and Public Assurance Group. And there are 4 key segments there, which are listed, which we've kind of segmented a particular representation. Age condition and specific groups, particularly in the third sector, advocacy and networking, NHS patient experience, particularly working with our health board colleagues across Wales, and digital and health and libraries. Now, I've counted, and there are 28 groups listed there. This is accurate as of today. Now, We don't have a meeting every month where we have 28 representatives always there. And it's not to say that 28 groups listed is everybody in the sector, because it's clearly not. But then they provide another connection to a whole series of other networks which would be interested in our work. The important thing for us is that the Patient and Public Assurance Group is an open group, so people can attend when they feel they're able to. We consult widely in terms of user engagement, and there are subgroups which sit off that from time to time, which have particular areas of interest. Now, what we're not trying to do, I suppose, is to replicate or to duplicate a lot of other groups which already exist. We can't do that. That wouldn't be useful for our time. It wouldn't be useful for the time of people concerned. But the important thing is to be able to have a listening ear so that we are connected to the most current conversations on digital inclusion, on data inclusivity and the like, so that we can bring them back to us. We can also use the network to be able to help us to understand how to reach hard-to-reach groups. And I'll talk a bit about that on a later slide. Okay, so to population needs. I've mentioned it's using the network to help us to understand that the whole of the population, all 3.1 million people across Wales. We, at the very early stage, actually, before I came on board with the programme, the early part of this year, there was a lot of work which took place, which was very much, focusing on some of those hard-to-reach groups and the strategies which we would need to employ, particularly to look at how we'd reach the homeless, how we would reach the traveller community, how we'd reach vulnerable patient groups, prison leavers, for example. Now, there's not always perfect answers and a rule book or a playbook which we can apply, but I think it's making sure that they're very much on our map, and we've got a plan of how to reach them, and we're monitoring how we're getting on. And I think that plays to kind of Harriet's point, which she kind of raised at the start. It's not just about utilisation of the NHS Wales app. We need to answer that particular point about what we're doing with all of these groups as well, and how they feature within our plan, and how they feature in plans which other groups are helping us with. I mentioned we're not doing this on our own. We have the forums there listed, which are very much helping us in our work. So I take a particular example. I know that we've, through Joe Dundon, who's instrumental in the Patients and Public group, we've had enormous help from Digital Communities Wales in terms of some of the training which we'll be providing to GP practices to help them and help people to be able to access the NHS Wales app and use it to book the likes of online services available in practices, to be able to help them with aspects of their health record and the like. And all the time we'll be capturing learning which we'll then seek to be able to roll out to others. So that network is really important, but it's not everybody and everything. I mentioned that user needs are at the heart of our design. Now, we've got a head start, or had a head start in a way, in that the NHS Wales app and the code base behind it was the same code base which was used in NHS England and their app. And they did a lot of work insofar as their user design to be able to develop their app, and a lot of experience since they've developed their app. So we were working hand in glove with our delivery partner, Keynote, and able to bring across a lot of that learning which is helping us. But that's not all. Of course, it can't be all, because there's very important, incredibly important local context here in Wales. And so we take both. We take what we can learn from England and learn from elsewhere and apply the local context of which all of our respective network are able to help us with. We have a firm plan which we want to be able to take our delivery approach to, and I think my next slide will talk to that and explain what we'll be doing over the next month or next few months, and provide you the detail of what's next. Okay, so the NHS Wales app private beta. We've, since the start of the year, or since November last year, that's when we really started developing the NHS Wales app, we've been building that core functionality. Over the last few months, we've been testing that functionality on a private basis with people within the service. Our intention is from middle of October is to go out to GP practices, 10 GP practices which have identified themselves to us and said, look, we're willing to work with you and be part of a test of that functionality which the app has got available. And we're going to reach out to 1,000 patients from across Wales, 1,000 citizens, to actually test that functionality for us. Now, I was at a meeting, and some of the colleagues in the room will know, at a Patients and Public Assurance group yesterday, where we were discussing that private beta, and we were discussing the particular conditions and characteristics of that cohort that we'd want to include. And it was almost not quite a wish list, it's a requirements list, which we want to satisfy ourselves for that 1,000 or so patients is representative, or as representative as it can be, of the 3.1 million citizens of Wales. Now, part of our approach will be reaching out to best part of 25,000 citizens and boiling it down to 1,000, which we'll do at the start of next month. Then we'll have a good eyeball on the data to work out how we satisfy those particular conditions. And if there are any gaps, then we'll adapt our approach and we'll work out how we reach out to accommodate, some of the potentially digitally excluded, or some of the people who have got less easy access to digital resources, so that their real-time experience actually is contributing to our development work for the NHS Wales app. It's also important for us to understand that process because, to a lesser or greater degree, we all find the adoption of aspects of digital technology hard at some times. The fact that we don't always put our hand up about it, that isn't a reflection that it's easy. And it's certainly not easy for me, and that's not an age thing. What I would say is that we're seeking to be able to draw those insights through our private beta, which will extend, as I said, from the middle of October through to the middle of January, to really get under the bonnet of how the app is working, the experience by citizens. Now, if we're able to satisfy all the conditions that the app is working as it's intended, we would then intend to go to a public beta where it would be available for citizens across Wales to download. But taking that step is a really important step for us. We're only going to do so if we are entirely satisfied that the app is doing exactly what it should be and is going to land well, be received well when it finally gets released. And our assurance groups, those that I've described, play a crucial part in that, in terms of guiding us, in terms of challenging us, and making sure that it's doing what it's intended, because we do not want to disappoint anybody. Okay, a map of Wales and the practices which we've worked with. We're starting with vision-supported GP practices first, because they're available first. Our intention is to roll out across all practices in Wales. But this slide is important because we'd like to be able to say, hey, here's the functionality for all GP practices to say, yes, we will do this. But that's not reality, unfortunately. We have to work in collaboration. We have to be able to explain the benefits. And in working in our private beta, we want to make this really easy for practices to be able to support. And so that's very much part of our approach, understanding the benefits and making it easy for others to be able to adopt. So that when we come to them and others on our behalf are able to explain that, so it's not just us saying that, that they are able to go, right, when can we be involved? When can we switch on that functionality? How can we support providing a lens on healthcare for citizens in Wales so they can be more empowered in their own care? As Joe would say to me, the conditions which we're looking at, into that sort of 1,000 or so we want in our cohort, those are the kind of top line headlines of which we're looking in terms of how to slice up that population. But we're always gaining insights from Patients and Public Assurance Group and others to make sure that we accommodate all. And so that's our challenge, accommodating all and getting representative feedback which we can use. Supporting proxy access. I put this up there because the app offers it, and the website offers a huge potential to be able to support the care of others, often those who are nearest and dearest to us, who may struggle with aspects of technology and what that means. We've all got families, and so there's been development through actually one of our other assurance groups as the lead, the Ethics and Information Governance Assurance Group, about how we provide access to data in the most appropriate way so that the needs of individuals are safeguarded, but they can utilise information and records which are pertinent to them to be able to share with others. For a time-limited period, perhaps, or for a more defined period of time, which enables them to be guided and supported, as opposed to having to reach out beyond their family to people who they wouldn't know. So that's a key part of the development of the features which are ongoing, and we'll be looking to, in time, be able to test that element of functionality as well. My last slide now. So where we need help? Well, of course we're going to need help from promoting the nature of the NHS Wales app, and supporting people to use it. And gaining that learning from private beta will be important to us in terms of understanding actually what's needed next as we move towards public beta, and helping us with our broader communications campaign. We have a communications partner which is geared up and ready, but the reason that you haven't seen kind of billboards on buses or anything like that is we have to go through this kind of managed development process. Once we're assured that it's ready to go, rest assured the communications campaign will switch into top gear and we'll be on our way. Training, I've mentioned the support of Digital Communities Wales in terms of understanding those insights and being able to apply those. We'll want to work with others who can see benefit and to reach out to groups. There's the element of a browsing accredited digital services. We're doing work with a partner at the moment which will help us in terms of improving the digital applications which are available within our core app, and being able to lay them out, to curate them in an effective way, to support the whole onboarding, so that as opposed to from time to time us having to use Dr. Google for our search or information, we've got accurate, verified information which is available for all citizens which they can access, whether it's to do with their healthcare or whether it's more to do with social care, available within our centralised gateway application. And the last bit about service transformation, well, mentioning it, we want to be able to put the NHS Wales app onto a pathway to improving functionality for all and empowering patients, but we recognise that not all necessarily would want to come on board with us at the same time. And I'm not necessarily talking about patients, I'm talking about clinicians and other important stakeholders. I suppose that the power of patient change and patient voice is going to be really, really important to us. So when people see it, that clamour for, why can't we do that? Why can't we have those services? That's going to be powerful to us over time, but it is going to take time, and it's going to take the soft engagement and soft work with us in the margins as well. I'll stop there, but hopefully that's a useful window in terms of what the NHS Wales app is seeking to do and how we're seeking to address inclusivity aims. Thank you.
Thank you, Matt. If anyone who isn't involved in the Patients and Public Assurance Group would like to be, Joe, do you want to put your hand up? I'm sure during the break, see Joe, she'd be very keen to hear from you and very keen to help you get involved. In the next half hour before the break, we've got two presentations, as I mentioned in my introduction, about digital in action and case studies, as we used to call them. First from Ariel Tai of Promo Cymru, who I know very well of many years ago, as Marco, the director, reminded me when we arrived this morning. And then from Scott Tandy of Knowith Housing Association. Scott, if I suggest when Ariel's finished, you just come up rather than me having to stand up again, that would be great. Ariel.
Hi, thank you for the introduction. My name's Ariel Tai and I'm Head of Development at Promo Cymru, and I'm going to be talking about the role of digital in service design, but most importantly I'm really going to be talking about good service design is all about involving people, and I'll be sharing a case study about that as well. So I work for a social enterprise and charity. We're called Promo Cymru, and we work to ensure young people and communities are informed, engaged, connected and heard. For about the past 15 to 20 years, we've been delivering large-scale digital services that help people to get the support and information they need in the right channels that they use. And from building on all of this expertise to be able to actually reach the most vulnerable people in society, we've built up a team that now supports and helps other people to do the same. So we work across the public sector and third sector to help people to rethink services using digital. So firstly, I want to talk about what a digital service is. And I have this lovely lady here on the right, because I think sometimes when we think about digital services, we start thinking about tech. We start thinking about virtual headsets or apps. I know there's a very good app being launched, so I'm not going to diss apps, but a lot of the time, we don't need apps and we don't need this flashy stuff. I love this quote because I do a lot of training in designing digital services. Many people come on board and they say, I'm not techie, I don't know much about digital. And at the end of the session, somebody said this, I thought this session was going to be really techie. Well, good news is it's not. I don't consider myself a techie person. It's actually fundamentally about trying to get people the best service that they can in the best way that we can, and painting that journey from the moment you need help to getting help in the most accessible way. That's never changed, and that never will change. So digital technology is a way to enhance how we access what we do. And I think sometimes we need to try and forget about we need an app or we need this flashy solution, and think about how we can use what's available to us to enhance services for people. Oh, this doesn't work now. It's a good example of that. So this sort of represents what I'm saying, really. This is off the gov.uk website. The objective is to develop services that are useful, usable, and valuable from the point of view of the user, and efficient and effective from the perspective of the service provider. And that's really what we're aiming to do. So it's really important when you start thinking about designing digital services to firstly understand where that service starts. And so again, forget tech and put that to the side and think about viewing a service from the perspective of the people who use it. So from the moment I need help, what's the next step and where do I go for that? And this is the most important principle that we have to remember when we're designing services. So we want to avoid the end solution for now and instead focus on what's the problem that we're trying to solve for service users. And the service starts, as I said, when that person first needs help. And we then need to consider that whole journey that they're taking from that moment to get the support they need. And very often, that's going to involve multiple agencies. It's going to involve third sector and voluntary sector organisations. It's going to involve public sector as well. So we're all part of that journey. What we're actually in danger of, we're trying to replicate sometimes in the digital world what we already do in this confusing way that we get support, and we could just replicate that whole thing online if we don't work together. So we have to think about that whole journey, and that is likely to involve multiple partners. So how do we do this? The great news is this has been done many, many times before all over the world to design the best products and things that we use today. This stuff, there is methods behind how you design really excellent digital services. And the good news is we don't need to learn about how to use every piece of tech as a provider or someone who's delivering support to people. But we do need to learn about what a good digital service looks like and how we get there, because then as leaders and as providers, we can all work to these processes to make sure that things are working for people. This process is called the Service Design Double Diamond. You might have seen it before, but there are other processes. You might have heard Agile. They very much follow the same principles. And that principle really is, as you can see the diamond here, and I'm going to talk you through it just really briefly, is that you start off with a problem. And the first thing is you have to thoroughly understand that problem that you're trying to solve. So that's why you can see that the diamond opens up there in that first box, because our first role is that we actually have to speak to people. We have to really, truly understand them. Who are the different people that are going to be using our services? Are these things going to work for them? What are their needs? Once we understand that, that's when we start to, the diamond sort of focuses in on that area. So we have a very clear understanding now of the problem we're trying to solve. When we start then developing solutions, the diamond opens up again because there's lots of potential solutions to that problem. and we need to start testing them. So again, like Matt was saying, we have to go through lots of testing with lots of different groups of people to make sure that the things we're designing work for them, and it's only when we've done all this that we actually move forward to that last part where we start developing these solutions. So in my job, I hear so often people come to us and they say, we need to develop an app. That isn't what we should be talking about. What's the problem that you're trying to solve, and what's the best way to get there? And all of us, this is really empowering because we can all learn these stages, whether or not we know the technical stuff or not. So I'm going to show you an example of this in action on a project that I worked on. So we partnered on a project at Promo Cymru with Public Health Wales. And we wanted to work with a group of young people and look at how we can make sexual health information more accessible. So what would the perfect sexual health service look like for a young person? What we know is that STIs are very high risk amongst young people. We actually know that the information isn't very accessible for all young people. Lots of them have told us this. It's really challenging to find where you need to go, the help you need. And we also found that young people were actually attending STI clinics at the wrong time, sort of wasting their time, staff resources, and resulting in fewer young people getting the support they need. We also know that sexual health is really embarrassing, and it's something that you might not want to talk about. So you do need to be able to be empowered to get that support yourself, because you might not have anybody you want to turn to. So we went into the discovery phase knowing some of these things, and that's why we did the project in the first place. But what was really important, again, instead of jumping to that solution, was that we needed to really discover what young people would actually do in a real life scenario. So in that discovery phase, you can set up a number of tests. So we went to a sixth form college, and it was very, very simple. We gave them a storyboard and we gave them a scenario at the beginning. So we said that you've come into school on a Monday morning and you had unprotected sex on the weekend, and now you've heard a rumour in school that Sam, this person you had sex with, has got chlamydia, and now you're, OMG, what am I going to do? So we gave young people this scenario and we said, right, now do it. You know, this could be happening to you now. But please make a note of every step that you're taking. So they got their phones out. They searched online, they found lots of scary things about chlamydia that they really were worried about, and actually they found the clinic. They found their local clinic and they found the time, and we were like, oh, this is brill. And then interestingly, where all of them fell down is that they didn't actually read through that information thoroughly. We used the example of chlamydia for a reason, because actually you need to wait 2 weeks before that's going to show up on a test. So there's absolutely no point going to the clinic immediately. And it very clearly says this on the NHS website, but not one of these young people that we worked with actually did that. They all went to the clinic on this storyboard, the next available opportunity. So although the information was there, and it was a bit hard to find, but they found it, they actually didn't process that information and take the relevant action. So what we did then was we mapped out, and again, this is showing things from the service user's perspective. So what's actually happening? That's what we really need to understand before we can make changes. So we've got a young person here, they're worried they have chlamydia, they search online, and then they find lots of confusing information. They find their local clinic. As you can see, they're a bit happier now. They're frustrated because they can't book an appointment. You can't book an appointment. They realise that actually to get there, they have to turn up to a queue and wait and hope to be seen in a very embarrassing situation where loads of other people might be. And this is actually how you access your care. You feel hopeful because you finally get to a health worker. Bearing in mind this is a school day, you've had to get a bus here because you were embarrassed to ask your parents to give you a lift. And then actually when you get there, you get turned away and you feel very upset and very frustrated, and you might not go back. This is obviously a very worst case scenario, but it was important for us to really think about this picture and what can be happening for young people. Once you have this, and this is the whole exciting thing about designing person-centered services, it's quite easy for all of us now, whether we are involved in technology or not, to make some suggestions about how this could be better. Because now we really understand what's happening, we can all start envisaging what a perfect sexual health service might start to look like. So we co-designed with young people and with health professionals, and we started thinking about how that could be better based on services that we use today. So we search online. We find a website full of youth-friendly information that's aimed at us. We find an online chat on that website, and we are able to actually type in and check with somebody. That person helps us to book an appointment, and they make sure the appointment isn't booked for 2 weeks' time because we've already spoken about and gone through the fact that we think it's chlamydia. And then we go to the clinic and we get sorted, and then we feel empowered. So of course, again, this is like an imaginary thing. We've designed it, in reality, putting this into place isn't as easy, but now we can see where we're going and what we want to achieve. So what we did is we then thought, right, well, we need to find a mini version of this solution. And what we found was a form called Type Form, and you can use a free version of it. We ended up paying for it, but it's like a logic survey. So we built a logic tree. And so what happens now is you go in and you specifically type your age, what you're worried about, who you are, what your concerns are, and it tells you exactly at the end where you need to go and what you need to do. You can't misinterpret that information because it tells you there and then what needs to happen, and you can complete this in 47 seconds. 16,000 people have now completed this, and it's making a difference to them being able to get to that relevant piece of information. But this is only one small step in that journey, and there's lots of other iterations. So it's about changing, I suppose for us, we changed one part, but then there was a whole range of other needs that we needed to address as well. So again, providing really clear digital information was important for young people. They were asking us things like, what happens when I go into the clinic? I want to know exactly what the test is going to be like. Do I need to do it myself? Do I need to take my clothes off? How do I get in there? All of these things. And so we started building in a whole range of different bits of information. But I think I wanted to use that example because actually really it's about creating accessible services. So you have to think about the person and their needs, and we have to understand what they use, and then we have to make services that are easy to find, easy to use, easy to contact, and easy to feed back. But really importantly as well, we need to make sure that these services are joined up so that the route for somebody, if we're seeing it from their point of view, is seamless and not as it is in a lot of examples today. So yeah, the final message really is that put people first and technology second. And the role of digital in service design is to enhance the experience for service users. Thank you.
Oh, there you go, jumping ahead. Hi everyone, my name's Scott and I work for Newydd Housing. I very rarely speak at events, but the opportunity to talk to so many people who share the same passion and vision as I felt it was too good an opportunity to pass up. I believe I got about 10-15 minutes to share some examples where our work has improved our tenants and the wider communities, access to technology and well-being. So I'm going to dive straight in. Almost 30 years ago, with the launch of the internet, lots of people are still excluded to digital services and therefore unable to benefit from the opportunity of the internet. Digital Health and Care Wales themselves stated that 11% of the population are digitally excluded. As part of the same document, it stated that the NHS in Wales is committed to enabling people to use digital technologies to manage their own health, well-being and care. However, many people who could most benefit from the digital services are not likely to be online, as this has previously been mentioned. Specifically looking at the housing sector, National Survey for Wales show that 17% people in social housing are digitally excluded, around 60,000 people. I believe the previous Health and Social Care Commissioner, who I believe perfectly summed up why I feel it's important to co-develop solutions to help tackle this in housing. He said, social landlords were often the one organisation in the community that had ongoing relationship and direct connection with the many people living with long-term health conditions, struggling families, and those in society that are marginalised and stigmatised. It became obvious that access to good quality, affordable warm homes has a massive impact on people's lives, improving their mental and physical well-being, and therefore life chances. Yet there was very little understanding of what social landlords did and the opportunity of engaging with them better could bring. So I've boiled it down to some of these 3 examples, which I'm going to share, which I believe have shown the biggest impact and furthermore, quite easily can be scaled up. You may have heard some before, but I think it's worth re-emphasising. So there were dwindling numbers of tenants attending our activities within our independent living schemes. As a result, we were finding it very difficult to justify spending between £100 to £350 average on events to benefit them very little few. The reduction of activities further isolated many of our tenants to a point where several said there was no point leaving their flat. Having discovered this as the problem, I went out and researched digital solutions which could, specifically looking at video conferencing, which would allow them to stream activities across all our schemes. However, as this was a long time ago, quotes were in the region of £20,000 to £30,000. Aware of the time I was spending on the work, I attended the NHS Hack Day as a last-ditch effort to try and get some answers to this problem. By the end of the day, and I'll say that again, by the end of the day, we'd created a test proposal which is still in use today. Within the first 10 months following installation of this work, and you can see some of the pictures here, we've streamed 30 activities and events across all 5 of our independent living schemes, including Q&A with the Chief Exec, Cuppa with a Copper, virtual quizzes, virtual digital support, Move and Munch, virtual cooking, and coordinated a number of virtual family Zoom calls to our most vulnerable tenants. Before I move on to our second example, I ask, how do you think them tenants felt attending those events? How can we build on this success to support the health and care sector in their vision to ensure services are accessible as possible? Digital Communities Wales website says the level of digital exclusion is higher in Wales than in the UK, with as many as 7% of the population not using the internet. Digitally excluded people are some of the heaviest users of health and social care services, so risk being left behind. One of the ways we've begun to tackle this issue across Wales is via the loan of digital equipment. Service users can borrow a device for a certain length of time to access a website or online services through their local library. This is an amazing initiative which I believe is now being rolled out across Wales. I'm proud to say that I've worked on it and have spoken to many of the participants who have accessed the scheme, and many have said the project has truly made a difference to their health and well-being. However, the painful truth is the solution was tested and in place 2 years prior to the launch. Once successfully tested the scheme, we required further funding of around £15,000 to £20,000 to roll the project out within a local authority, which was unattainable for the partners. It was only when we reached out and spoke to third sector, private sector, voluntary organisations and those working with the health and care sector we were able to secure the funds and launch the project in October 2019, I believe. What we learned here was collaboration is essential for success. Lack of physical activity can lead to a number of health conditions, heart disease, obesity, blood pressure, I think the list goes on. Despite this, physical activity levels worldwide are poor. Unfortunately, this is no different in Wales. Wales has a population of approximately 3 million, of which 664,000 are children and young people under the age of 18. Swansea University carried out research recently looking at physical activity data of 60 countries and found that children in Wales are among the least fit. To help address these concerning statistics, staff at Newydd set up an innovative Get Fit Wales pilot to test if the use of step trackers as a method of evidence in physical output amongst younger people aged 13 to 16 living in RCT would increase physical activity if presented with incentives to local healthy vendors, leisure centres, local gyms, free healthy food options and healthy shop vouchers as rewards for achieving their personal targets. Providing access to local healthy vendors through our reward scheme has provided a secondary benefit in the sense that it's raised the profile of those organisations, helped stimulate their economy and create and retain valuable jobs, supported families and strengthened the local communities. Following positive results from the participants on this pilot, over the lockdown period, the project gained the support, I best get this right, from Cwm Taff Morgannwg and Cardiff and the Vale Regional Health Boards, from Cwm Taff Morgannwg and Cardiff and the Vale Research Improvement and Innovation Hub, Public Health Wales, the University of Trinity, St David and Wales Institute for Digital Information to help build on the success and widen the age of participants referred into the programme. Together, through Get Fit Wales and the support of the partnership, we've now supported over 500 unique participants with free access to opportunities to improve their physical and mental health and general well-being. How can we improve on this project? With your help. Together we can achieve more. Thank you for listening.
Thank you, Scott. Thank you, Ariel. I mean, that's the most disciplined group of speakers. I must have been something about the pandemic. You've all been on courses about how to stick to time. Thank you very much indeed. And I think that just briefly before we break for coffee, those last two examples, I think, go back to something I mentioned right at the beginning, what success you can get when people who understand the communities that they're developing things for do it. And I think I've long held the view, as many others do, that the social housing sector has got so much to offer us in terms of supporting people and services, because there's probably not a sector who understands their people greater than the social housing sector. And I fear that as time goes on, I think it's going to become more and more important as social housing becomes more important. So thank you very much, all the speakers. We break now for coffee, 15 minutes for those people watching online. That will be just after about 17 minutes past 11. We'll come back. And as I say, we've got a couple of speakers after the coffee break, and then we've got a panel session and an opportunity for you to get involved in the discussion as well. Thank you all very much. Hope you enjoy a cup of coffee and what looks like something that's not very healthy over there. Thank you. Okay, briefly, just to introduce the next section, a couple of words is that I thought that we're all different, and quite often there's a tendency to talk about people as groups of people when looking at inclusion, whether it be, I'm sure Helena would echo this, whether it be older people or people who have a particular condition. When it comes down to it, one older person is always going to be very different from another older person. One man is going to be different from another man, one woman is going to be different from another woman, and it goes on and on and on. I think we need to recognise that when we're looking at inclusion, we need to get beyond the community group approach and get to this individual user. And I think hopefully the next three presentations from Myra from CDPS, I'll let her describe the organisation, from Hugh Owen of Alzheimer's Society, and from Mark Davis of Compass will bring some depth to that issue, that we're all different and how do we find out what users really want and what they're about. So without any further ado, and probably the best way, if it works, is if when Myra's finished, Hugh, you come on, and then Mark, you come straight on rather than me taking up time. Myra.
Good morning. So I'm going to talk about building inclusive digital services. Feel free just to jump in at any point. Some of the examples I'm going to give, I know people in the room have worked on, so do feel free to add, do feel free to ask questions, do feel free to say anything. In some ways, for me, giving a presentation actually makes it easier if people help me along the way. So, as I said, I'm Myra and this is Harriet. We job share. We're the CEOs of the Centre for Digital Public Services. But I'm not here to talk about us. I'm going to talk about other people and what inclusivity really means. So I want you to meet Graham. These are obviously personas, but they're based on evidence. So Graham is the kind of person for whom Tuesday nights at Iceland are really, really important. Does anyone here know why Tuesday night at Iceland is really important? No, because probably none of us shop at Iceland, do we? That's because you get 10% off if you go on Tuesdays, and it's a really good value deal, especially if you're spending, in really tight resources going to Iceland. So Graham is the kind of person who relocates to Pembrokeshire dreaming about his retirement, but actually things are really, really tight, and it's really problematic that the state pension age is much later than he perhaps anticipated 10 years ago. So he's just about getting by, and of course he's going to have the kind of health issues that many of you in the room are much more familiar with than I am. So I'm going to then use some evidence that we've got about what life is like for these people. So I'm going to refer to 3 discoveries that we did, that we commissioned in partnership with many people here, and talk about some of the challenges that if you do user research when you're designing your services right at the very, very beginning, will save you time and money and effort downstream. And I suppose that's the most important message from me, is that if you don't get the service design and the user research design at the very beginning of the process, right at the beginning of the process when you have your policy intent, all the money that you spend in the world on your procurement will not lead you to having a successful outcome. So we did a piece of work with Sally and Joanne in the room here, and we looked at some of the stresses and strains of the digital services that had really escalated into the market as a result of COVID. When you do discoveries, sometimes it's really frustrating for your stakeholders because they feel like it just tells them things they know already. So there are some things here that you guys will really, really recognise. But there is nothing like the painful experience of having your users tell you all the things you know about your services that are really difficult, but actually which you just don't want to tackle, because if you do, it's going to be so painful and difficult, but it's worthwhile facing them. So a lot of this and a lot of things about accessing primary care are all about stress. And actually, I reflected afterwards that I must have been really stressed when I was putting together this presentation, because I only meant to write stress and I've put it in bold as well. So just to remind you all, in case you don't know, one of the, so our research, our primary care, accessing primary services research after, the changes that came around with COVID, are to do with the 0830 stress, which actually probably some of you in the room can guess what I mean by that, which is just, everyone knows if you ring up and you hang on that phone for long enough, it's going to be really stressful, but if you hang on long enough, you're going to get through in the end. It might be 20 minutes, it might be 50 minutes, but just keep hanging on. Although I have to say, some people actually just pop round in person anyway, because it's less stressful to get around than it is to ring up and hold on. So what some GP surgeries have done, which I'm sure you'll be familiar with, is they've just moved that to another fixed time. But of course, all that does is just move the bottleneck to another fixed time. But then the other thing that's happening is trying to manage prescriptions and access to prescriptions and test results. And what surgeries have done, and Sally, do jump in if I get any of this wrong and I say anything inappropriately, is said, that's okay, we know we've got the bottleneck at 8:30, so could you ring up between 1 and 3 to get your results? Or it might be 2 and 4. But then, of course, what happens is Graham and mums and people like that, they get really stressed remembering when it is, and they think, oh my God, I can't remember what time it was, and then actually I've forgotten that Jamie's got rugby club after school and I've got to be out between 2 and 4:30. Do you know what, I'll just ring them at 9 anyway. It doesn't matter, because so actually people still ring up at the wrong time. Then we've got all the stresses and strains, and we have to think about this. We had a long debate in CDPS about whether you talk about end users or users, all the stresses and strains for staff. And one of the things I would really feed back to all my colleagues in health working here, looking not so much at Graham but at your staff, don't just give them another tab. Please, please, please don't just give them another tab. They're so stressed by how many tabs they've got open on their computer system in front of them and how many they're moving across and how much they've got to cut and paste. So anything that we think about introducing in health, we need to be thinking about data and interoperability. And the other thing I want to say, which I think is very apparent in Wales, and Helen and I were just discussing this actually, is there are lots and lots of people sort of doing the same thing, really frantically and really passionately, but it would probably be more effective if we were more aligned and more joined up. And we'd be able to meet the needs of people like Graham better if we did that. When you do user research, what's really noticeable is that there are some things that we can do that are actually really, really easy that help us to meet the needs of our users. So I'm going to talk here about an example from a very different area. Some of you may live in rural locations and engage in rural activities, but I want to talk about work we're doing with NRW about managing waste, managing land, all those kinds of areas of our work. And here you have a very different example, that often what you find is that it's the wife who maybe does, or the partner who does the kind of applying for grants and management and bookings of sort of holiday lettings, and in many cases in Wales they might be a Welsh speaker first. And so we've been looking at a lot of the kind of content that NRW makes available on their websites. And one of the things that our user research shows is first of all, we need to really think about Welsh, and this is kind of across the board on a lot of our Welsh websites. We need to think not about designing in English and then doing Welsh translations, but actually designing from the beginning in Welsh and English, because it really, really makes a difference. And we need to think about our language. So we tend to talk about processes. We talk about processes all the time. That's how we live our lives. We're all working in bureaucracies where we're very focused on processes. Users don't care less about the process. They just want the outcome. So we need to be really careful with our websites and our communication that we address that. The other thing we need to remember is that within our user base, we may have really, really big users who are very professional themselves, or who have the budgets to employ professionals to do jobs for them, who will speak a professional language. And then we have people who are very small amateurs who will speak a different language. I'm just going to give you a great language example from local authorities. I was talking yesterday to someone who's dealing with local authorities and the issue of fly tipping and litter. And if you have a website where it's not clear, or people don't have the option to report litter or fly tipping, there is a big risk that when someone wants to report a load of litter in the local park, that you send a fly tipping lorry out to deal with it, because on the website they couldn't accurately distinguish between fly tipping and litter. And actually, if you can manage to make that distinction, you can operate a much better service. It can be much more accurate. But if that website doesn't work, or if that service doesn't work, that information won't flow effectively and it could result in more cost. And the other thing just to say is that we speak a language where often we use words and terminology that we use day in, day out. For our users, like this lady, she might have to apply for a license or permit, think about which one we call it, once a year. So she won't remember what she called it a year ago. She won't remember what the password is. So familiarity and regularity are really important concepts to include as well. Then just for my last example, this is about sport. So this is very typical in that you've got people engaging in community sport who want to access grants for which will make a really big difference in their lives. So we need to make it really easy for them to get their grants. So we did a piece of work with Sport Wales, a Discovery and an Alpha, all about how to reach out and include hard to reach communities. And often, these are not necessarily, high educational. The people that Sport Wales want to reach with their grants are the hard to reach, if you like. So this is really important. And we made some really good improvements here. One of the things that, which you'll all be familiar with, and the presentation earlier really touched on this, is we need to have a service that you access digitally where the user flows through nice, simple, easy steps. Ask the right questions and we can guide people through really effectively, as opposed to them jumping around all the time, which is really difficult. And another thing that we tend to do is ask people for supplementary information. So often when you're applying for a grant, you have to provide lots of supplementary information. And we assume that's really easy, but it can present a barrier. So classic one in sport, small sports club, run, I'm sure you'll all recognise it if you've got any kind of children or your neighbours, small club, run by volunteers, no one's got much time, but actually we're doing it out of goodwill. It's a really, really good thing to do. People have done their basic checks and stuff like that, but then they want to apply for a grant and they need a safeguarding policy. Forget it. They haven't got a safeguard. Who knows how to write a safeguarding policy for a voluntary sports club? So think that's not an intentional barrier at all. Not an intentional barrier at all. But that's the kind of thing that can easily put people off applying for a grant. And this piece of research was really, really fascinating because it showed to me as well that as an organisation, you need to present your passions and your interest. Sports World wants to give money. Let's be passionate about it. Let's use passionate language. Let's not talk about eligibility and criteria. So for me, that's all about reducing the barriers to entry, enabling people to use our services so that no one gets left behind. I really liked the thing that someone said earlier about the inverse care law. I've never heard that. Is that the right phrase? That was absolutely fascinating because for me that really goes to the heart of this. So it's great. We've got this nice strategic context, the digital strategy for Wales, reinforcing that message that no one gets left behind. This is about the kind of being out there, the community level. CDPS works on the other side of the equation, which is about improving our public services and the people, the skills and the capacity and capability of the organisations who deliver them to improve our ability to deliver better public services. Sorry, I haven't expressed that very well, but hopefully it'll become clearer in the next few slides. So, it's about holding up the mirror. Not very nice sometimes. Someone said to me yesterday, the problem about holding up the mirror and asking ourselves how well we're doing, we know we're not doing as well as we could be right now, but at least we know we're not very good and we can just hang on and we can just keep going. If you really tell us what our users need, then we're going to have to address this really difficult big problem, and how do we do that? So to use a cliche, I would say feel the fear and do it anyway, because it's beholden on us to do the right thing and to try, even though that journey is really, really painful. And CDPS actually is really all about being part of that journey to make it much more easy and do the right thing. So we do need to hold up the mirror and recognise the problems that we have. Existential question here. I think there's a concern about, should be some pictures there, but designing services around people and the people who use them. This is about policy intent and user need, not user want. So I want a grant. You know, I just want to apply for a grant. I want a grant. Government, I'm afraid to say, wants to offer that service, but imposes criteria such that the users have a need. And I think we need to sort of recognise that, and that there is a distinction, because that's the space that we're playing in, which is we will all have policy intent. We will want to nudge, we will want to make, we will want to ensure compliance. But the user needs to be able to interact with us effectively to enable that policy intent to be delivered. So don't think of this as just, well, we're just pandering to what the users want. You're not throwing the baby out with the bathwater. It's a shaped and contested space, and that's an important area to be in. So in terms of, here's the CDP cell. In terms of what we bring to the party and what we want to do, we want to bring skilled people. We're very lucky we can appoint and bring in skilled people, and we're really committed and in the process at the moment of building a permanent workforce based here in Wales that understand Wales, that want to work for the good of digital public services in Wales. So they're agile teams. We have had a quite temporary workforce in the first phase of our setup, but we're changing that now. And they work with organisations, not for organisations. So that means we're not going to just come in and go, yeah, we'll deliver all that. You know, that's great. We're off. We've delivered the thing that you procured us to deliver. It's about long-term partnerships and really, you know, if you're managers and leaders thinking about staff that you can mobilise who can grow and develop and learn and be part of this process, so that ultimately we will have a long distance relationship with you, or less intimate relationship with you, and you will be able to work and deliver, and your staff and your teams. So for example, if you have a traditional IT team with more traditional project managers, but you think there's talent and skills here, these guys want to develop, they want to improve and work more in the digital space, there's an opportunity to do that. And actually, when I spoke to the CEO of Sports Wales, what he said one of the most powerful things of the experience of working with us was actually that his project managers now felt delivered to, empowered and trained and skilled to work as delivery managers in digital programs. So it's about development. So yep, we put together multidisciplinary teams. They can be of different shapes and sizes. We try and adopt all the kind of proper digital agile ways of working, and we'll help you to work in the open if your teams aren't used to doing that, and that's quite daunting and scary, but it can be a good journey as well. And the whole point is about lasting change, because as we're all saying today, you know, digital changes are here with us, you know, for good. And I think that's it. Yeah. Thank you.
Lovely. I'm hoping I'm not going to be going backwards, but who knows. For those of you who don't know me, and there are many, many new faces in the room for me today, my name is Hugh Owen. I'm the Senior Influencing Officer at Alzheimer's Society Cymru. My background is actually in public affairs and policy, so I'm going to be coming at this from, I think, a slightly different angle to some of the previous speakers. But before I get going, I just want to say that this morning has been brilliant so far, and a lot of what I'm going to say I think you might have already heard, so I might be done a little bit quicker, which is always a bonus. So let's see if this works. Because of my public affairs and policy background, my first thought when I was putting this together was, I know what I'll do. I'll chuck all the stats on the screen because that's what I'm good at, that's what I do. And so I did. We at Alzheimer's Society Cymru know that there's an estimated 50,000 people living with dementia in Wales. We say an estimated because, and I've got a microphone and an imaginary soapbox, so I'm going to bore you a little bit here. Our diagnosis rate for dementia is actually about 48% at the moment. We don't know half of our audience. The stats there as well, I've split them up into the over 65s and under 65 because of early onset dementia. So those with a diagnosis under the age of 65 are classed as having early onset dementia. And for us, that's a fairly important distinction, although it's getting less and less as time goes on. And again, those figures are estimated because, well, we just don't know. And it's something I'm going to come back to later about how actually knowledge of your audience and understanding your audience is vital. And when designing services, particularly digital services for people living with dementia, as we come out of the pandemic, not knowing if that 50,000 number is correct is a real big problem. I've also put the stat in there about a third of people living with dementia live in rural Wales and a third of people living with dementia live on their own. Those are fairly self-explanatory, I think, when we're talking about digital services and access to services and making digital work for all, because I'm sure we're all probably preaching to the choir here, but we're all aware of issues accessing telephone lines, broadband, things like that in rural Wales. And if you live in rural Wales and you live on your own, accessing those things can be a complete and utter pain if you don't know where to start, you don't know where to look. The last stat on the bottom of there is what we call our prevalence figure. It's where we expect to hit by 2050. It's 100,000 in Wales, so our estimated number is going to double inside the next, I'm going to go with 25 years, it's not, but it's close enough. What this means is we are going to see an explosion in our dementia population. And it is vital, absolutely vital, that as our services move more online, move more towards the digital and trend that way, that we take into account that rise. Because dementia, for those of you who don't know, is a neurodegenerative condition. And lots of dementias, there's over 100 types, I'm not going to go through them all this morning, so you're all right. Because of that neurodegenerative element to the condition, people will often find themselves experiencing an earlier time in their life. And for those of us who in this room will go on to develop a diagnosis of dementia, and a good number of us will, unfortunately, that's life, we may well end up thinking or experiencing our life as it is now, or our life as it was 10 years ago. And what that means is we're going to view technology and access to digital services as we see them now. And it's absolutely vital that as we design our digital services here in Wales to make sure they work for people, and in this case make sure they work for people living with dementia, that we build in almost an element of redundancy, so we're not trying to teach people something new when they're experiencing technology or using technology as they see it today. Because the easier we make it for people with a diagnosis of dementia to access technology, the easier it will be for everybody to access that technology. I've put this quote up after seeing you on the agenda, and I thought, why not? Why not? And it's absolutely right. But I'm actually going to, I've almost put it up there to play a little bit of devil's advocate here, because while I completely agree with what's written up there, I'm also of the opinion that digital access and access to non-digital technology is also a right for people if they choose not to. And this is something I'm going to talk about a lot today, is that choice, the element of choice, and making sure that people are included in the middle of all the decisions made about them. We talk about in dementia care the team around the individual in the middle with everybody else around the outside. And this includes digital services, it includes everything. And the example I'm going to use to illustrate my thoughts on this is banking. About 3 weeks ago, went abroad for the first time since the pandemic. It was great. I ate too much, I drank too much, and I had a fantastic time. Going abroad, I thought, hang on, I need euros. What am I going to do? So I went and found one of those brilliant online banks, and this is not an advert, they've not sponsored me to say this, but they're fantastic, that allows you to set up an account digitally, transfer your money across, use the card abroad, no fees, no nothing like that. Excellent. Absolutely fantastic. I can use that account here, I can use it anywhere I want in the world. But if I'm living with dementia and I've always used cash and I've always had access to cash, and we cut that access off because we've so focused on the brilliance of that technology, the ability to set up an account instantly online, to transfer the money in, to use the card, we're going to alienate every single person who wants to use cash. And we cannot do that. So whilst digital access is absolutely a right, we also need to make sure that people have the right to choose whether or not they go down the line of digital access, because it doesn't work for everyone. And I know that's probably a slightly controversial thing to say, stood here in front of this audience when we're talking about digital and technology, but it's true. It really, really is. Because if we're going to include everybody in our society in the digital journey, we have to make sure that they're included in a way that is beneficial to them and suits them and their needs. Otherwise, all we're going to do is alienate people and push them further towards loneliness and isolation, which is something we cannot be doing. To illustrate how digital technology works, and with people living with dementia, and to take away from some of the statistical side of things, I thought I'd tell two stories today, because you might have guessed I can get up on my soapbox and I can talk about things like this till the cows come home and bore you all until you're desperate to leave, which is not what we want. So I thought I'd tell two stories. The first story illustrates the bad side of things, how not to put people living with dementia at the heart of everything we do. And it involves garden centres, which is brilliant. I love a garden centre. I've got a massive jungle of houseplants in the house, and actually garden centre cafes do some great cakes, which is not good for the waistline. Prior to the pandemic, at Alzheimer's Society Cymru, we got an email from somebody living with dementia based in North Wales. And they said the same things as me. I've got a massive garden, I love gardening, I like a cake, trip to the garden centre's perfect. They said, but I've got a problem with my local garden centre. I've told them I'm living with dementia because it's good for them to know I'm a regular visitor. If something happens to me while I'm there, they know what's going on. The garden centre turned round to this person living with dementia and said, that's good to know, thank you for telling us. We've got a bit of technology, we've got a bit of kit that can actually help keep you safe while you're here. What we've got is a little bracelet for you and a little bracelet for your carer. You put them on, and you can wander around the garden centre freely, no problems. But if you go outside of a certain range of your carer's bracelet, an alarm goes off. And it tells your carer that you're more than 50 feet away or more than 100 feet away. What do you think about that? And the person with dementia went, that's not good. I don't like this. And the reasoning behind that was twofold. Number one, they had their choice and their freedom taken away from them. If they're sat in the cafe with their carer and the toilets are 150 feet away, that carer's got to get up and walk with them to within 50 feet of the bathroom so they can go to the loo. If they want to go off and look at a different section of the garden centre while their carer is doing something else, they can't do that. They were physically tethered, not physically obviously, but you know what I'm driving at. They were tethered to their carer by a piece of technology that was enforced on them. And the other reason they didn't like it was because the garden centre assumed. They assumed that the person living with dementia had memory issues, had capacity issues, and wasn't in a position to consent to the choice. Even though it seems like, in the wording, they offered the person a choice. They said, would you like to use this? Ultimately, there's no choice there at all. Because even though they'd asked the question, would you like to use this, They hadn't consulted with people living with dementia in the community when designing the technology at all. They'd assumed that everybody living with dementia who visited that garden centre would need to stay close to their carers, and they'd designed the technology based on that false assumption. That's the bad. The good, to flip the script completely, actually comes courtesy of a project developed in cooperation with the Life Sciences Hub here. And I've got to get this right now, eHealth Digital Technology, the Attic team, and a lady called Kimberly Littlemore. I've just seen a great grin from the back of the room there. Somebody knows what I'm going to say now, don't they? Excellent.
It might be a completely separate project, but I know Kimberly and she does fantastic work.
Yeah. So Kimberly used to work for the BBC as a producer. Did lots of documentaries and things like this. And both of her parents live with a diagnosis of dementia. Kimberly does a lot of caring for them. She noticed at one point that her father, whose dementia was more advanced than her mother, was having problems with some basic tasks. Making a cup of tea, putting his shirts on so he was buttoning them up out of order, so completely lopsided. She tried everything to identify what was causing these problems and to come up with a solution to fix them. What she ended up doing was partnering with the teams I've already mentioned here, the Life Sciences Hub, the Attic team, and developing a set of glasses, because her dad was a glasses wearer, that tracked his perception, so what he was looking at when he was doing things. At this point, I would love to show you a YouTube video, but I don't have the technological skills, ironically, to embed it into a PowerPoint presentation, so you're all going to have to Google, but I guarantee you it will be one of the best 12 minutes of your life sitting there watching this video. Because she spoke to her mum and dad, identified these problems, involved them in the creation of the technology, these glasses. So they were made to fit her dad's face. He was involved in everything, little cameras in them that tracked his perception. And what she found using these glasses was that the problem with her dad's shirts, I'll start there, was that they were patterned, like the one you're wearing, the check shirt in the front row there. And because of his perception issues, he was struggling to pick out the buttons on the shirt against the pattern. So he was buttoning them up wrong. Losing his ability to dress himself, to put his shirts on properly, leading him to require extra help, extra care that would have cost more money, more time. So having discovered that, Kimberly made a really simple switch. She got rid of all of his check shirts, bought him a load of plain shirts. Put the glasses on again, did the buttons up, no problems, happy days, can dress himself. The issue with the tea, making cups of tea in the kitchen, quite simply, the kitchen was too cluttered. He couldn't pick out the tea caddy and the mugs against the background of the kitchen. There was too much stuff there, and his eyes were being drawn to bright colours. I'm sure we've all seen those Nescafe Azera tins, like the silver ones with the bright orange lids, you know, the ones I'm on about. Because of the bright orange on the lid, his eyes were being drawn to that, and being drawn to that, and being drawn to that. So instead of making tea, he was making coffee. It's a really simple thing there. Remove the clutter. So you put the glasses on him again, having removed all the clutter, and he could make the tea. Two really, really simple fixes discovered because of the use of technology that was developed in conjunction with the people who needed it most. Her father and her as the carer put them both at the centre of it, designed the technology that worked for them, that identified the problems and allowed the fix. Two different stories, one bad, one good, and I hope they show just how important it is to actually put the people you're designing the technology for, you're building your services for, at the heart of everything you do. And sitting at the back this morning I was thinking, there's a lot of engagement being talked about already. This is brilliant. I might not actually have anything to say this later on. What am I going to do? But I'm hopeful that those two stories have really driven home the importance of it and the need to engage with people at every step of the way. So I was asked, and Mark was like, how do we make digital work for all? And I was thinking about this, and I was thinking about this, and I was thinking about this. And this is the section of the presentation I really struggled with, because everything up to this point has been, I think, fairly self-explanatory, fairly good, fairly useful, I hope. And this was the bit I struggled with. And after speaking to some of our service users, some of the people we work with closely who have a diagnosis and who care for those with a diagnosis, what we were told is, what I was told is, you can't and don't try and make digital work for everybody. Because if you try and make digital work for everybody, you will find yourself stuck in a loop of trying to make constant improvements and nothing will ever get done. As long as you talk to your audience, find out what they want, engage with them and put them at the centre of everything you're doing in digital and in technology, and make sure that what you're producing suits the needs of those, or the needs of the majority of those who are going to use your services, and make sure that there is an option available for those who physically do not want to access your services, choose not to access your services, or cannot access your services for whatever reason, then you will make digital work. If you try and make it work for everybody, you'll end up pleasing nobody and things will fail. I normally do a questions bit. I like to put it in there anyway, just it's a holding slide I have. So that's me. I think I'm just about within time. My email is on the screen now. I'm around afterwards if anybody wants to pick my brains or challenge me on anything I've said, because I like to be controversial sometimes. Diolch yn fawr iawn. Thank you very much.
Good. Right, I think I'm the only thing between you and lunch, I think, so I'll try and skip on as much as we can. I'm Mark Davis, and this is my colleague Jenny Phillips. I'm going to talk to you today about two digital hardship projects that we've run over the last 12 months. And brilliant projects. I've been involved in digital inclusion and digital support for over 20 odd years, 22 plus years actually. Been involved with Bevan Exemplars, been involved with working with Nominate, involved with winning Welsh NHS Hack over the years. And when something good comes along, you get a gut feeling for it, because I think you get that feeling in your bones. And these two projects, we were desperate to get them in front of people today, just to try and share the experience, because I think there's something, if they were scaled up, maybe, and there's a potential for them to be scaled up of really good value. We both work for Compass. For those of you who don't know, Compass, formerly named the Wales Cooperative Centre up till about the spring of this year, rebranded Compass. We're involved with delivering social value, developing the foundation economy and offering social change across Wales. So a range of different programmes. I won't talk about those now. Come and see me in the break, and we'll talk more about Compass generally. Dwi'n hapus I drafod yn Cymraeg. I'm a first language Welsh speaker, so if anybody's got any questions or would rather speak to me in Welsh afterwards, dwi'n hapus I wneud na hefyd. Okay, so the digital hardship projects, there were two programmes. The first one was funded by Welsh Government around about 12 months ago to now, when they had concerns about a third wave of COVID coming along over the winter months. And they were concerned about who would be there to support those living at home or being released from hospital. How would they cope without digital support? The second one then, we ran that programme up from November till end of March, and subsequently then Bridgend County Borough Council took on the same model slightly. We tweaked it slightly, which is the good thing about this programme is that it is adaptable. And they ran another 3-month programme, which again proved really successful. And we've heard a lot today about end users, and we heard a lot about the patient, or whatever you want to call them, the person living at home. So who better, in our eyes? We've been involved with working with organisations that were serving the end users, but we weren't directly involved with the person at the end, the person in receipt of care. So who better, we thought, to give us that information than the caregivers themselves? So this programme had kind of 3 types of outcomes, 3 beneficiaries type of thing. One was the end user, the patient, or the person being released from hospital, or the person in receipt of care at home. Secondly, it was the caregiver. And thirdly, it was the organisation that caregiver worked for. And thirdly, we wanted to embed something. We just didn't want to kind of be involved with that intervention, not embed something when our backs were turned, nothing would happen. So we also developed a person-centred digital support plan, which goes into the care, everybody who receives care at home as a file. So they got loads of different agencies coming to support different carers, different people, different family members. So this personalised digital care plan then was put into the file, so that ongoing support was recognised, that digital formed a key part of that person's care plan. So what the programme was, in a nutshell, really was, we empowered the carers to tell us spot opportunities of hardship out there. If you identify a problem, tell us what the problem is, fill out a really simple 1-page form about what the intention was around digital, give that back to us, we will assess that and try and find the ideal solution for that person and the specific need for that person. We will award some money to the organisation to buy a device that will make a difference to that person's life. So central to it all was the carers, and these for me are, I've got a lot of respect, because a lot of their work goes on unseen. They're unseen angels in my eyes, because having had them support my father in the late stages of dementia of his life, the work that these people do is very, very underestimated and undervalued, I think. So another part of what we wanted to do was try and upskill the role of the carer, so hopefully they are seen as more than just somebody that goes out and does menial tasks. They are seen as opportunity spotters to kind of to break the cycle, or to be early warning system really of problems pending. We were aware of the challenges. We'd worked for many years in the digital inclusion sector, so we knew what the problems were around barriers. As I said, we wanted to empower the care staff, because but the problem we had with them when we worked with them as an organisation is they couldn't be released to be given training. You couldn't get a batch of carers in a room and deliver training to 50 carers. They were working in sociable hours. When one was on leave or one was sick, somebody else had to cover for them. It was almost impossible to get them in one space to upskill them. So what we did was flip that on its head, really, and try and do an on-the-job training. So by coaching them around and identifying digital needs, basic entry-level digital needs of mainstream kind of items like, assistive technology, speakers, through tablets for communicating with friends and family, through to a specialist software that they could be used if they had certain conditions. So by empowering them to understand that, support that, they would see the benefits coming through the people they were delivering care to. But we needed to prove that concept. We had to give it a go. So very much like the service design methodology that's been talked about today, we had to kind of test the theory, really. So we adopted an agile service-led approach. We had a lot of the insights prior to this programme. We only had a couple of weeks to turn this around, because it was a Welsh Government contract. We had to go really quick with it. So we had the insights, and we had some resources. We had a small budget of around 30,000 to purchase kit for these organisations and hand out. We adopted an automatic helpline, because this was delivered by one person. We had one member of staff delivering this, and you'd be amazed to see when you see the outcomes at the end, is that how many people were supported. So we had an automated call system, like a helpline. It's only 300 quid. It took away all of the administration load, that we could focus on the delivery. And as I said, one member of staff, Jenny mainly, and a bit of support from myself when we were assessing applications and looking for solutions to deliver the programme. And some of this has been already said today, ironically. I think Helena mentioned this word herself in her opening statement. So we had to get close to the people. We had to reverse social distancing and get to the root of the problem. We had to understand the people that were doing this job on a day-to-day basis. And we had to respect that. We had, we had to put all biases and assumptions aside and really get into the role of how these carers were doing, the challenges they were facing with, the problems, the connectivity, the issues, the confidence. We had to really take that on board. So we built 2 sets of personas, one around the person in receipt of care, and the key thing that came out of that persona was the mood. If we were able to enhance the mood a little bit of the people in receipt of care, the carer said it's a much easier task for us if they're in a good mood. If we turn up trying to give care and someone's in a grumpy mood, it can be a real pain of a job. So we try to emphasize a fair bit around what can we do to enhance the mood of the end user. And then also the care worker themselves, the support worker. We had good knowledge of it, but again, we're not talking about people with high levels of digital skills here. They're people, their skill is helping people. That's why they do the job. They're not coders, they're not website designers, they're just caring people that help others. And so we really have to take that into account as well, and constantly evolve this persona of both the care worker and the person in receipt of care. As I said, we had compliance matters to put into place because there was information being shared, so we really had to quickly put that into place. We had the transaction of funds, and we wanted this to be swift. We wanted to be not bureaucratic, an easy fund to access. That was really important. A lot of the information was anonymised to speed that up, and the carers said that was one of the key parts of the success for them to be involved in the programme. It was fuss free. It was literally one form, boom, and within 4 days they had a payment to crack on with the device and embed that within the care plan. So the simplicity of it was a big thing. I'm going to hand over to Jenny now to do a bit more detail on the outcomes and the stats.
Yeah, so I'm just going to talk a bit about the outcomes from the project because I think it's really interesting to see what the impact was of the projects that we did. So over the course, this is the 2 projects that we did. So this is combined together 111 individuals or families supported by the hardship funds. And the average spend wasn't that much, it was £295 per application. And as you can see, the table gives you an outline of the sorts of devices that the fund supported people with. Vast majority was tablets. I think particularly with older people, particularly people that struggle with using a keyboard, a tablet is a really useful device. It's really easy to use. It's quite easy to teach somebody to feel confident using a tablet. But we did a lot of work supporting people with smart speakers and smart devices, particularly people with sight loss, particularly people with dementia who would have struggled with any kind of input with a screen. Really useful to be able to voice control things, set up reminders. So that's just a bit of an outline. And as you can see, we did quite a bit with preloaded SIM cards and MiFi devices, sort of mobile Wi-Fi devices, because a lot of the people that approached the project just did not have an internet connection and didn't have the resources to fund that for themselves. So that was something that we were able to help with that was really, really beneficial. So in terms of the needs of people that approached us, as you can see here, this is a breakdown. Obviously, they could have more than one need, but this is a kind of analysis that we've done of the sort of needs that people had. 87% of the applications that we had were about social isolation. It was a huge issue that people approached the project with. A lot of people living on their own, but not always. A lot of people with caring responsibilities being very isolated in those caring relationships because of the lack of support or the lack of feeling that they could leave the house and the kind of worries about the person that they were caring for. So just feeling really isolated and separated from the world and their families. So that was something that I felt that we really helped people address. And as you can see, the quotes from people kind of speak for themselves. We had a lot of applications, obviously, given that it was focused around hospital discharge, from people with quite chronic health problems or had had a kind of crisis in their health that had led them to be admitted to hospital. And the fund was able to support them at this time of crisis. This is a woman we supported in Bridgend who had diabetes and which had caused her to have quite significant sight loss, and she was struggling to manage her condition. And the device that we supported Bridgen Care and Repair to give her helped her manage her diabetes because it automatically sent readings to her clinical team, and she was much more able to manage at home and be independent. So there was a lot of that sort of support with people who had sort of mental health crises as well, often younger people, and that again supporting people with apps and mindfulness, meditation, and being able to manage their own health using technology and remain independent and keep well was a big part of the project. One really good feedback that we had from Bridgen Care and Repair, a really important partner in this project, was one person they supported in their hospital to home scheme. The fund was, because it's so fast, because we were able to do it really quickly, like 4 days average application turnaround, we were able to actively support somebody to leave hospital, because issuing a smart speaker enabled them to be able to set medication reminders, and that was the kind of critical point that they really didn't feel safe on discharge, but having that in place enabled the discharge to happen. So I feel like, you know, there's some real value coming out of quite a small intervention, but as long as it could be fast and as long as it could kind of meet the need that was there when it was seen. We did an awful lot with unpaid carers. This is a guy, Malcolm in Gwynedd, who is a full-time carer for his wife who has quite severe dementia. And he felt very responsible and didn't feel able to always leave her. But through the fund, he had an iPad and he also had respite carers. But his wife was able to access Welsh songs and would sing and be very sort of moved and uplifted by the songs that she was able to sing. And he felt going away and coming back, seeing her singing and happy, was really, it made him feel as a carer much more confident to leave her alone. And there's some other quotes there about the support we've done about supporting people to live independently using technology. It's interesting the ages of the beneficiaries, and I think this tracks really well to something that Helena mentioned. We did expect a lot of the people to access the fund to be older people, and they were, but we also had a significant number of younger people who have ongoing chronic health conditions, who were unable to work, who were living in severe poverty, who were using food banks, who were in fuel debt. And the fund was able, because we weren't tied to an age range, we were able to support anyone that was kind of in a hospital for whatever reason. So that was a really good point of the fund.
So just to finish off really on a few key notes, well, meaningful, the top one there, I think just that it got straight to the root of the problem. That was the key thing about it really. There was no blockages along the way, and it was a fast and it got to the problem, and it involved the carers, because they are the experts here. No matter how much you talk about end users and how much we assess that, they were the critical people involved in this whole cycle.
Yeah, it was really fast, and that was something that we had really good feedback from the organisations that we supported. That it wasn't a process of sending this application, not knowing who you were sending it to, getting it back really fast. If there were questions, I would ring them and I would talk to them directly, and we would try and work it out together, so that we knew that we would get this support where it was needed, when it was needed.
Simplicity was key as well, and I think some people have mentioned today is complex problems are complex to deliver. This was a simple program, simple to deliver, and it had really good outcomes. So I do stress that sometimes simplicity is key, and try to find that simplicity in everything you do, really.
I think, again, just to reiterate, that the building trust with organisations was really important. It's about collaboration. I mean, Compass, this is what we do. We try and collaborate with organisations. And the important part of it was not to be an arm's length fund, it was to be working on the ground with individuals who was providing that direct care and building trust with them, saying, look, you know me now, you can come to me if you've got questions, ask me and I'll help you, and if we can help the person, we will. And that sort of support and that link with organisations, I think really created the confidence to use the fund and to actively access it.
The knowledge area was key because it wasn't just a program where you give someone a bit of kit and you walk away. You know, there was purpose behind that kit. There was thought behind it. There were specialists involved. Digital Communities Wales were involved if training was needed for that particular organisation. If that was fit for purpose, we liaised with specialist organisations, AbilityNet, RNIB. The people that really knew more than we did. We knew what was there, but they needed. They had to be involved to be a part of the solution as well. So that knowledge was key.
And I think, again, the collaboration element was really important for us, not just us collaborating with the organisations, but I hope what we did was link organisations together, particularly in Bridgend, to say, look, did you know that this service over here was doing this, and your individual person you're supporting might benefit? And this, so I think hopefully now that the fund's closed, what we have left behind as a bit of a legacy is that sort of stronger networks in communities that can draw on each other's support, and they have the knowledge and the skills perhaps to be a bit confident. And I think one of the really nice pieces of feedback we had was about how important it is as a member of an organisation working on the front line to see your colleagues doing something and to see them using an app that's really transformed somebody's life, and to think, oh, I could do that. It's almost better than any sort of sit-down training. If you see your colleagues doing it, if you see the value of it on the ground in front of you, then you're more likely to kind of pick it up and use it yourself.
So this model is there. It's adaptable to many solutions. As Alina also mentioned, we're on the cusp of something really quite tragic coming on the horizon now with this cost of living crisis and stuff. I really do believe, my gut is telling me, this needs to continue in some way or form to help the current situation, which is probably worse than when we run this back 12 months ago. But that adaptability, this service design approach, not kind of set in stone, being able to tweak it to suit different needs, that's there. Governance model is there. We can run with this tomorrow if need be, and it is of high value. I would really love, we've got a Welsh Government has invested across Wales now in a huge Internet of Things infrastructure, LoRaWAN network. This is a portable sensor. There's about 12 different sensors in there. I'd really love to try and engage some of the carers to understand, if there was a case of risk somewhere, that they could leave a device like this in someone's home, and then that could be monitored centrally. The scaling up this model has a real potential to make a real difference to a lot of people's lives, and the people that are at the worst possible condition at the moment and experiencing hardship. So thank you for your time today.
Okay, while the panel is assembling, there's four, so it's Helen, Sally, Marilyn is somewhere, there's Marilyn, and Myra. Do you want to... thank you very much, Mark, Jenny, Hugh, and Myra. Some really important messages in there, which I'm sure will get picked up through the discussion. Not least of which, Mark, it did bring back some memories of when I was at the Co-op Centre and you'd get the call from the Welsh Government in mid-November saying, we've got X, can you spend it before March the 31st? But the other key message around that is how for not a huge investment you can make a huge difference. So, if I could probably just, if I introduce people quickly, you know Myra, you know Sally from earlier on. This is Marilyn Bryan-Jones, who's a very recent joiner, joining us as an independent member on DHCW and as a specialist in EDI, Equality, Diversity and Inclusion, and Helen Thomas, the Chief Executive of DHCW. And while people are thinking if they've got any questions or comments they'd like to contribute, I've got some that have come through on Zoom, which is wonderful. The technology works. There are people out there. Great, thank you very much. But if I could just perhaps ask Helen, who just to give any sort of brief reflections on what we've heard this morning in the context of the work that we are engaged in and will be doing.
Yeah, thank you, Simon, and actually thank you to everyone who's here today. It's great. It's that people thing, face to face, and thanks to everyone who's watching online and contributing. Doesn't it feel like there's a for me anyway, a coalition of the willing in the room? Actually, there's a real energy around this, and I think from our perspective, Digital Health and Care Wales, we've got we're in a hugely privileged position, but a huge responsibility that comes with that position. And I think today is perhaps building on the work that we've been doing so far, and thanks to Joe and Matt who talked earlier around the work that we're doing through the programme to develop the NHS Wales app. But it's more than that, isn't it? I think there's some really strong messages for us as an organisation and for all of us. That piece about walking in the shoes and having the user at the centre and making sure that actually it's all sorts of shoes that we're walking in, actually, because not one size fits all, does it? So I think that was a clear message for me today, and ensuring that in everything we do as an organisation, in all of the services that we develop or we provide, that actually that user voice is at the centre and at the heart of what we do. And the other bit for me was the strong feeling of coalition, of partnership and collaboration. So I'd like to do more of this. I'd like to ensure that we are talking across sectors, and it's an area that Joe's been doing some great work for us in this area, but it's not something that we do every day in Digital Health and Care Wales, and actually it needs to become more kind of central to the way that we do business. And I know that Simon, that's close to your heart and is something that you really feel strongly about. So we're here as kind of we're not here just to listen. We are going to be fully kind of participative and be part of that kind of co-production, bringing Prudent to life and the good work that Sally and co are doing. So yeah, it's been really great. Thank you.
Thanks, Helen. Who'd like to? Anyone got any questions or comments? Or okay, I'll go to the. I like this one because it refers to something I said. Dylan Roberts, not sure where you are, Dylan, but asked the question. Love the intended consequence of inclusion. Does this mean an aspiration for 100% digital inclusion for all, or does it mean keeping paper, industrial age processes, etc. in place? So I think that gets to the heart of what is our ambition. I mean, what's the end point? Is it that if there's one person who has poorer access or poorer quality of service, is that a failure? So who wants to pick up on that first? And who wants to go first? Go on then, Helen, while you think about.
Yeah, I don't mind. I think there's a strong message that we've heard today again, isn't it? That one size is not going to fit all, and we leave no one behind, which I thought that was really struck me this morning. To do that is already people are being left behind, aren't they, in terms of the progress that we're making. So it's a tough call, but we've got to make sure that we do that. I think that there's a huge service redesign and transformation to be done across health and care services. I'm not sure we're quite ready for it. I don't think we know the answer to Dylan's question. But it wouldn't it be great if we didn't have to have these huge libraries full of paper that I'm sure Dylan is reflecting on, and a number of us and colleagues in the room have had experience of managing all of these they are last century paper processes. But actually, this is going to take us a number of steps to get there. But the more we can reduce the reliance on paper, the better. The more we have born digital information that is more accessible, the better and more inclusive that becomes.
Sally, I mean, perhaps you'd pick up as well, because you were talking about the other side of the coin, isn't it? Is around the providers of the services getting on board. I mean, it took me 3 weeks to get on My Health Online because I had to speak to the practice manager. What's that about? So Sally, perhaps pick up on it's the other side of the coin in terms of the provider and getting them on board.
Yeah, so I think, working or not, so I haven't got my.
Yep.
We can't widen inequalities due to clinical teams or organisations not wanting to participate digitally with patients and people receiving care generally. But rather than complain about that, I think we need to walk in their shoes and understand why it is that they can't do that. So very often at the moment, it's because the system is under so much pressure that people just don't have time to go through that change management process. So I think it's incumbent on us and organisations to think differently about how they support clinical teams to do that change management process. And that's a real challenge in primary care, because actually, from my perspective, there's a real gap in how we support change management and delivery across 400 independent GP practices, for example, across Wales, who may not be able to do that themselves. So how do we do that, and how do we work as a community to achieve that? Otherwise, we're going to drive inequalities, because of that difference in readiness and digital maturity, if you like, across clinical teams and organisations as well. So it's really vital that we tackle that, and that's a new thing, and it needs dedicated resource. And the other thing I would just make a point about is the last two presentations have given us fantastic examples of where small amounts of money make a massive difference, and we repeatedly fail to give those things core funding, whilst defaulting to putting millions and millions and millions on things which on the face of it look good but aren't, or maybe a sticking plaster. So we really need to flip the way we think about how we invest for high value.
Thanks. I mean, perhaps I could ask you, Marilyn, I mean, I know the answer to this. I mean, where you think our ambition should be across a whole wide range, not just digital services. You and I don't know diddly squat about digital.
No, I definitely don't.
But across a range of the whole range of public services, and ensuring what should the ambition be in inclusion.
Well, I think just what's been said this morning by every speaker who's come out really about putting the heart and the user at the heart of the services is about. I think historically we're developing services which make it easy for us and for us to look at the stats and be able to prove what we want. And I think, I liked you earlier on what you said. It's about what does the user want? How do they best access the service? And I can give you an example. My son was poorly this week, so I had to go to the doctors. The doctors used to be open 8. I didn't know about the 8:30, which I do now. But the girl was there, not on the phone, not speaking to anybody. She said, "Could you do me a favour? Could you just ring?" I thought, you sat there at the table, so you could open the door and take. So I went and rang from just after 8 o'clock, and I got through at 25 to 9. Now, to me, that's an absolute nonsense. That's a good opportunity to show, actually, we're here to provide services which are for the user. And so for me, when I speak to people in the community, because I'm involved with lots of different community organisations, they feel that digital, there's people are not very positive about it because they feel it's a tier that's been put up to make it more difficult to get to the people who provide the services. And so there's a lot of work that needs to be done around trust and confidence, and actually saying actually that's not what we want to do. We want your information. We want as much as we can because we are there to help you and we do want to work together. So for me, I think that's, if it's flipped around, I think that we'll get at the end, as the first question is, we haven't got all the answers, but we'll come up with something which is more about what we want as organisations and also what the person at the end of it wants as well, rather than us doing things that will give us more information to prove or disprove what we want. And for me, there's just huge gaps as well because people are not happy to give that information at the moment as well.
Myra, is there anything you want to add? I'm not sure if you're mic'd up still, but you need to use...
I think I can just shout. I think one of the problems with this is that because change in the digital marketplace is moving so fast, it isn't a problem we're going to get rid of, actually. It's probably a problem that's going to get worse. And one of the speakers spoke earlier about, it was the dementia one, about accessing, in the here. We are going to be excluded in 20 years' time because we're all going to get old and we're not going to be up to date with the changes that are happening. So I think there's something about anticipating exclusion as well, and that it's going to happen, and making the services that you're launching as inclusive as possible and as effective as possible, so that when we have to concentrate our resources, and so as you beautifully illustrated this morning, work with the voluntary sector and third sector to target those people, there are still resources available. So for those who are able to access and included, make it as simple and as cost effective as possible, and anticipate and build for a future where there will always be people who are going to be excluded.
Thanks, Myra. Just thinking about, do take the microphone because it's not for here, it's for the people who are listening in on Zoom because the feed is coming through. Marco. It should be on.
Is it on?
It
On,
is.
yeah. So it's Marco here from Promo Company, just reflecting on the question. And so we run the contact point for young people in Wales. So it runs 16 hours a day, every day of the week. And so you'd expect that young people would be completely digital and etc. So just to let you know, 25% to 30 to a third of the contacts are through phone. They can contact through instant messaging. They can contact through chat. We provide lots of digital information, but still, that's the amount of young people will phone. So for us, it's always been important to allow all those methods of access into the service. They may come through first digitally because they don't want to talk about something, they're too scared, and then they will go maybe talk back to us. Sometimes they're so complex, the position they're coming in, that they need to speak to someone. So as an organisation, we're totally for digital, we're completely for it, but I think it's about how good can we make our digital so that they can go there and not forget those other bits that actually are really crucial to people.
Pick up on that. It's the complexity of access, isn't it? And this is one of the dilemmas that we have, in that we can do what we do with digital applications, but there's an awful lot that goes around it that means we need to work in partnership and have the support and collaboration of others, because they need to be doing it in order to provide the access.
I'm involved with a young person's organisation as well.
Marilyn's mic'd up.
Sorry, sorry. Really loud. With a young person's organisation, I like what the gentleman said at the end, because during COVID, where people weren't allowed out, the engagement went down and people didn't want to go online. Well, you know, it's the opposite to what people thought. And as a result of that, at the moment, mental health is a real big issue within the communities in which I'm aware of because of that. Because the issues they had there weren't dealt with and they've been exacerbated now. So there's some real things that, if there was a face-to-face opportunities at the time, which it wasn't because of COVID, could have been dealt with further down the line, now a couple of years down the line, that they're real issues that are difficult really to tackle overnight, really.
Did you want to come Sally, was it? Yeah.
Yeah, I wanted to pick up the point about access to care and the 8:30 issue, because I think it illustrates a point that Ari made really well in your presentation, which is that if you try to digitise a process that isn't working, you just get a digital process that isn't working. And that's and access to primary care at the moment is a prime example of that, because if you don't have enough appointments on the end, you know, you're just going to digitally not access what's not there. So what we need to help my primary care colleagues do is to completely redesign the way services are developed, not just for urgent access when you're having a problem on the day, but how we do chronic disease management, you know, and all of the other services that we provide in primary care, so that we're releasing enough capacity to be able to deal with the sort of digital access that we've been talking about. So we need the double diamond, I guess, again, and for the whole of those services in primary care.
Go on, huh?
I know I've got the mic as well. I think that's Marco. I think that, you know, you've kind of hit a nail on the head there, haven't you? And I think it chimes with one of the other speakers this morning, who I think it was, said about, you know, don't take choice away. So we need to progress, and we need to provide digital channels to interact and communicate and provide health and care. We know we want to do that and want to do more of that. But actually it can't be kind of, you know, instead of what some of the things that we're doing, and we've got to make sure that that choice is available for those who wish to interact in those ways. And sometimes the telephone is the best option, actually, when you want to have that remote consultation. And we found that in COVID, even though that we quickly developed digital channels and, you know, digital opportunities, actually the telephone is more than adequate for a lot of those interactions when somebody just wants to talk to someone.
Yeah. Okay. You might want to give the microphone to Matt, because I got a question from I presume North Wales. A lot of practices in North Wales, and I'm going to have to explain this, folks, now, use EMIS, which is a GP. It's the GP system, GP computer system, one of the systems that is used. So when do you anticipate you will move from just piloting with Vision, which is another GP computer system, software system, just conscious of the population of North Wales already feel like the poor relation across Wales, so this would provide a level of assurance from. So it's around what the process is for rollout, and it also goes to the heart of, which is an interesting one, when you develop new digital systems, the complexity about having to work with existing systems. So you might want to pick up on that as well, because it's not an easy playing field, is it? And I think Jenny Lee's behind you with, oh, you got it.
I'll stand up. No, it's a really valid question. We would have liked to be rolling out without any division between the two kind of predominant systems in Wales, Vision or EMIS. Our challenge is that EMIS haven't been able to do the work which we'd have needed to be able to roll out with them. But we have a plan where we'll learn from the rollout with Vision, and then we'll move that across to EMIS in March. So it's looking like March of next year, and that will allow us to be able to roll out across Wales. We've still got the important work to do in terms of service transformation with all of the practices, but we're keen that the same offer is available to citizens across Wales. So that's our approach. We'll take the learning from our private beta and apply it. But no, there is absolutely no intention of leaving anybody out. So rest assured of that. Is that helpful?
Yeah, that is. I mean, I think it's who said this and about what? I can't remember. It's a journey, isn't it? The app. It's not an event. It's more of a journey. I just wondered whether anyone would like to pick up on this issue of interoperability and whether it also has an element of how we achieve inclusivity around it in terms of, I know the app, for example, will be available on a phone, on a tablet, on a computer, so you are trying to widen as much as possible the access in terms of what people have. But the complexity of interoperability in a country of only 3.1 million people, and what impact that has for us. Helen, do you want to?
Yeah. I mean, we're in we are quite a small, intimate country in Wales, aren't we? 3.1 million people, and it's great that we can get in a room like this, to represent kind of so many communities in Wales. But it's an awfully cluttered ecosystem when you look at it through a digital lens, actually, and we have lots of existing systems, as Matt just described there, with our two GP supplier systems. You can multiply that by X for the myriad of systems and services, and some of those systems and services are not going to allow us to work in a kind of more digitally orientated way, where it's people and process that are first and then the technology comes behind. But actually, I think the approach that we are taking with the new and with services that are directed at patients and citizens actually are about laying those foundations. So Matt talked earlier, and we've heard a lot about the NHS Wales app today. That is kind of the tangible thing that people will see and be able to kind of interact with. There's a whole raft of things that'll need to go on under the bonnet to ensure that actually that starts on a journey that can evolve and grow really, really quickly. That has to be based on kind of really open standards and open ways of moving data around, so that we can, and we've never actually seen that successfully done anywhere, but you truly can get into plug and play in that health and care provision space, so that we have suppliers, we can say to them, if you want to interact with NHS Wales and you've got a proven innovation that provides added value in terms of the intervention, then this is how you connect into NHS Wales. Here's all the things you need to do that provide all of the safeguards and ethical considerations, but also technically this is how you connect. And there you go, that's how you do it. So that we become far more open and we have the capability to innovate, I think, at pace in a way that is more joined up than we're able to do at the moment.
Go on, Mara.
I was going to say it's really wonderful having been here today and been focused on user-centred design. But for me, that is the starting point. that's the kind of basis from which we all should move forward. And I've got particularly passionate recently about procurement, particularly here in Wales. So I think there's something about we've got a lot of smaller organisations, and a lot of us are procuring from quite large, often monopolistic suppliers, and we're missing a trick. we need interoperability, we need data interoperability, we need APIs, we need open standards. We really need to look at our procurement because, as we all know, doing procurement well is really difficult. And once it's in place, you're often locked in and tied down, and your options for change and transformation are really limited. So I'm getting, much to my own surprise, getting really, really passionate about getting procurement right, actually, because I think that's really important in the process.
We all get there in the end. Over here, Jenny Lee.
Thank you. I've got two probably points to make. One very specific. I work for Uwchgynhadledd Cymru, so one is a specific point about accessibility for blind and partially sighted people. The other is a more generic point, probably more aimed at the people from here, colleagues from the health community. Absolutely. I mean, I've enjoyed hearing a lot about kind of the accessibility aspect today. DSPP will know it kind of. I'm either representing my community or banging on a bit when in terms of the development of the NHS Wales app. But the presentations that we've had about the importance of user input and focusing on that, I just want to emphasise, because during COVID we had far too many incidents. We know that there were public health messages that came out that were using, for example, videos with text with no voiceover, which was for blind and partially sighted users was as good as a social media post with lift music. You know, there were vital public health messages that were being missed as a result of a lack of accessibility. And this is you know, a year or two ago, so this is reasonably recent in terms of thinking. We're not talking 10 or 15 years ago where you might have expected that usability and accessibility weren't at the heart of the planning of these activities. And I would also say, you know, in terms of the inverse law, if you take poverty, without getting into a misery bingo with the other condition-specific people here, but if you go on, you know, you've got poverty, you've got rurality, you've got social isolation, if you take away one of the two senses that is your primary way of getting information, essential information, on top of all of that, say blind and partially sighted people, I would say, is probably your first call, you know, your first stop along the way in checking whether what you're doing is going to be accessible to a wider population. And again, if you're talking about older people, you know, once you get to over 75 age group, you're talking about 1 in 3 people who will be living with that a sight condition. So, let's say user input, absolutely, I just want to continue to see the focus on that. The other is a more general one, and it's the health colleagues. And it's Sally, in one of your part of your presentation, you talked about the increasing number of people who are living with chronic conditions, and that being one of the challenges. I would say for health colleagues, take a social model approach rather than a medical model approach. What you're actually talking about there is the impact of those chronic conditions on their ability to live independently. That's the challenge. The chronic condition itself and the management of the chronic condition is not the end point. The end point is the impact that is going to have on their ability to live independently. And I think that's sometimes lost in conversations that I have with health colleagues.
Sally.
I completely agree with you. And I suppose that's why I made the comment about the last 2 presentations, because when the health system views it in that way, it means our responses to it are incomplete or sometimes wrong. And it means we direct resources inefficiently or just frankly not to where they can have the biggest impact. Because in supported self-management then is not a it's not a medical intervention, it's a social intervention in a way, or at least in part, but it does require specific thought and investment to do it well. You know, all too often we see it as, well, it's self-management, so we don't need to do anything about it. On the contrary, we need all of these tools, we need information presented in such a way that people can assimilate it and act on it. People need to know where they need to go for specific types of support, whether that's technical support or health support. So I completely agree with you. And we probably, I mean, I would be very interested to work with this group, with this community, about how we present that message back to healthcare organisations and finance managers so that they can get reassurance that this is a really good investment and it's going to improve people's lives, improve people's outcomes, but also reduce acute healthcare utilisation and therefore give us more resources to manage this really challenging time that we're going to face over the coming winter and years ahead.
Thank you. And I think your first point, John, is well made, and there are going to be some key tests, aren't there? And there are going to be lots of tests around of inclusivity, but clearly a critical test will be around how that group of people how we support that group of people with a visual thing. And I don't know whether you, Matt, you want to say a few words about where we're going on that or not, just before I bring in the next question. You may not want to, but you can if you want.
I only to say that. Yeah, hopefully that works.
Yeah.
Only say that, you know, John and RNIB Cymru are very much plugged into the work which we're doing, and so we were only discussing yesterday about the volunteers which John's already fielded to be part of Private Beta, making sure that we include those, because as well as being, I suppose, cohort stakeholders in helping us, there are also people who will then be, I suppose, the catalyst for helping others. And so we were just having that discussion this morning and making sure that they're included, matched to the practices which are involved, and helping us with our learning. So that's about what I want to say. Thanks, John.
Thanks, Matt. Should be on still.
My name's Lowry. I work for the Royal College of Physicians, and I think we've heard some fabulous case studies here today, lots of great examples of innovation. But I'm just wondering what the panel think about spreading that best practice. So if there's something that we're really good at in Wales, it's having little pockets of money that fund really great ideas, but then it doesn't necessarily get rolled out in a successful way so that it changes the system. Sally, you talked about, you know, flipping that funding. What do you think are the practical steps that we should all be taking to move the conversation forward? I think if we're all here again in 5 years having the same conversations, which isn't beyond the realms, let's face it, you know, what should we do in the next, you know, in the next year, in the next 5 years, to make sure that we are back again maybe in 5 years doing this, but talking about progress that we've made? I think that's the really, how do we reduce that variation in services?
Who wants to go first?
Have a go. It's really, really difficult, isn't it? And the system is not set up to deal with that at all. But we are the system, aren't we? So I think this is a targeted piece of work, possibly with individuals in this room and others, to think about a process by which we adopt some of these high-value interventions. And by that, I don't necessarily mean spending millions and millions and millions on new tech, but actually getting the most out of what we've already got, and, you know, enabling the sort of access and very sort of simple interventions that we've seen today that make a massive, massive difference. How do we support services that are going to become available behind the NHS Wales app? Because the app is just a gateway to stuff. It's just, you know, that's not the important bit in a way. It's just, I don't know if any of you are Lord of the Rings fans, but it's the one ring to bind them all, if you like. Not that I'm Sauron, I promise you. But I think things are so challenging within the system now that we can't sit here and go, yeah, it's really difficult to spread and scale, isn't it? We need to get the right people in the room, and that's a takeaway for me today, is to talk to some of the people that have been presenting today, talk to Helen and others about how we involve our colleagues in Welsh Government and in the senior leadership in the NHS to do this differently, because everybody wants to do it. It's just that our mechanisms and our processes are constantly taking us in another direction, and we absolutely need to flip that.
I put you on the spot now, Myra, because Myra, you're relatively new to Wales and having worked in Westminster, so whether you can tell us whether you think it's bad mainstreaming best practice in Wales, you should see what it's like in Westminster. I'd be interested in your experience of, I mean, admittedly it's a short experience in Wales so far, but whether you...
Yeah, so I would say the great wonderful thing about working here is that everyone is still in the room. You know, no one stormed out and taken their cricket stumps and their budget and, you know, all the rest of it and, you know, blah-de-blah-de-blah. And I love that little phrase, spread and scale. I'd not heard that before. I think it's really difficult because, you know, we are tending to work in smaller organisations that are quite localised and democratic, and that's really wonderful. But then we all have our boards, we all have our KPIs, we all have our limited budgets, we all, you know, so it's very easy to become siloed. So I think the best thing that we can do at the moment is stay in the room, try and collaborate where there are opportunities, form communities of practice, and I really like the idea of communities of action, because it's all right being a community of practice and sharing and listening to each other. Take some action, take some risks. I think we can make a difference, but I don't think it'll be easy.
Yeah, and just really for part of this for me is, you know, adoption. I reflect back actually on our response to the COVID pandemic, and actually, whilst there were lots of brilliant new things, actually most of the huge benefit came from, you know, using what we already had or improving and then using what we already had. And I think that is it's a shame, isn't it, actually, Larry, in Wales, that we find that spread and scale so difficult. So I think that there's something we can all do, and particularly, and I think you're right, Sal, this is a team sport, isn't it? And actually we've got to make sure that we get, you know, all the right players on the pitch to actually to start to do something that's different, because you're right, we could end up here in 5 years' time if we keep doing what we've already been doing, because it's not working at the scale and the pace that we need it to. There's something for me about being able to evidence that, though, and really we've got the digital strategy for Welsh Government, and we've now very soon going to have the refreshed digital strategy for health and care in Wales. The Welsh Government will be publishing. I think that gives us a bit of, okay, it says this is what our ambition is, but actually, where are we along the path to achieving that ambition? So we, in Digital Health and Care Wales, are doing some work to see how we can assess that through digital maturity. And that means more than, you know, how what digital applications we've got working in our hospitals, although we will need to understand that. Actually, what does that mean from our community's perspective? And actually, what is it that we could be doing? And from that, you start to get in one place kind of an oversight, if you like, of where new interventions are actually having an impact. And like we've seen today, some of these are fairly small scale, but they really are working and they're adding value to communities. So we've got to surface that story and surface it right up the tree, if you like.
Just before I begin a question here, I'll make an observation, Laurie, is that the total dysfunctionality of funding arrangements, and I don't think this is unique to Wales, where the NHS is almost on an annual one in terms of where it goes, and colleagues in this room will recognise this, or you might be on a 3-year funding regime, but every 3-year programme's got to be innovative. Well, can't we just do what is working? And maybe develop it and make it a little bit better? And that just drives behaviours, doesn't it, within organisations through the bizarreness of the funding regime. There's a question here.
Thank you. Philip Scott, University of Wales, Trinity St David, recently, still living in England, unfortunately. Great panel, great discussion. A couple of barriers occur to me from this conversation. One is culture, and one is monolithic institutions, and the two seem to go together quite often. And I just think about ways that we can address that. Obviously, culture is a slow burn, difficult embedding of change kind of problem. Institutionally, there was an interesting recent report from the Health Foundation evaluating the NHS England partnership with the Virginia Mason Institute in the US about quality improvement. And one of the key success factors seemed to be that they got the boards of what were competing organisations to actually meet together in a kind of non-competitive environment and talk about shared transformation. And even after this invested programme came to an end, they're still doing that. And there's some you mentioned evidence, there's some interesting evidence about even financial benefits. You know, we know that roughly 30% of healthcare spending is wasted. it's finding those pockets of wasted money and reinvesting it in these agile reinvention of service design that we're talking about here. And I just wonder if there's, as well as this coalition of the willing, is there something more formal that needs to be done at board level with these institutions to make sure they really are working together on transformation rather than just competing in the traditional way of the NHS, unfortunately.
Go on, Hab.
I mean, helpfully we don't have an internal market in Wales, so but that doesn't mean there isn't competition. In some of our systems and processes kind of engender, you know, the way you get money for investments in Welsh Government means you're competing against your neighbour, isn't it, for money? So there is definitely a huge kind of desire, if you like, to start to work in a more collaborative way for the nation of Wales, but ensuring that we kind of are equal in the way that we do that. So I think that there are a number of events planned, actually. There's one coming up next month, a Team Wales event, they call them, where you have all of the boards, all of the executive teams from across NHS Wales coming together to kind of network, to learn and listen from each other. And one of the topics will be Wales has partnered through Improvement Cymru with the Institute for Healthcare Improvement to really drive that kind of quality agenda. We've done some of this stuff before, and then kind of it doesn't quite land there. I think that there's nothing like a burning platform, and we certainly have one of those now, don't we, in terms of the financial climate we find ourselves in. There's no new money that will be coming in to Wales to support this stuff, so we've got to do something different to be able to sustain and improve going forward. So having improvement at the heart of the thinking, but doing that as a collective, I think you're absolutely right, because that level of collaboration has to be there. And that's very much a topic around kind of the, you know, the Team Wales table, if you like, that collaboration. We're not going to get out of this if we have organisation-centric kind of mindsets in place here. It's got to be kind of, we all play our part as part of what we're doing for the wider good.
Anyone else want to add anything? Okay, I've got time for one last question, which, if you're happy, Scott, it's for you. It's I don't know who, it's from someone listening in Anglesey. Ernest Morn. Great to hear about these projects. One question about Get Fit Wales, and this goes back to our conversation a moment ago. Will it be Wales-wide in the future? You'd like it, I'm sure.
I guess you took the words out of my mouth. Well, it's called Get Fit Wales, so we hope so.
Yeah, and that is the dilemma, isn't it, of actually getting things that work to get the funding, to get the support, to get the buy-in.
Yeah, however, just to jump on there, as this, as I said, led by a partnership at the moment, the next test is, I believe, Cwmtaf Morgannwg, following which, you know, we'd love the help of you lovely people to pass it into its next iteration. So,
thank you.
Hope so.
Any other? No. Thank you all very much. Thanks to the people on the panel for your comments, your contributions. We've got one thing we want to do as DHCW now, which you're going to have to bear with us for a moment, is one thing that I was keen on and Helen was very keen on, we did at the earliest opportunity, and then when we were organising with Compass and WCVA this event, it seemed an obvious place to do it, is for DHCW to commit itself into our work in digital inclusion in one particular way, which is to sign up to the Digital Inclusion Charter, which we're about to do now. See, during the pandemic, you didn't get the big checks anymore, did you? You know, the wonderful. So we're going to sign up. Helen and I are going to sign this, and please bear with us for a moment, and then please do join us for a bite to eat. What I think I'll do is probably make sense is just we'll do that, and then if I just make some closing remarks rather than, and then you can all get on and have something to eat while we sign this thing. Is thank you all very much for coming along. Thank you all to the people who've been following us digitally. It does mean that you can reach a much bigger audience with the conversation, the messages you want to discuss, you're keen to discuss, and none is more important than ensuring that those digital applications, those digital innovations that we introduce into the future don't have, which a number of people have picked up through the morning, those unintended consequences, and we end up with a post-digital inverse care law. I mean, something that none of us wants to see, particularly in Wales, where we, as Sally pointed out, we still experience the inverse care law that was identified 50 years ago. So thank you all very much for coming. Thank you very much for all the speakers and the contributions. They really have been great. I'm sure we'd all like to just express our appreciation to them in the usual way collectively. Some thanks to Neris, who our translator sitting over there, to Orchard, who are helping us put this all together, to the Life Sciences Hub for hosting us, and to the comms team within DHCW who made it all happen. And one person there's always one person who's responsible for all of this happening, these sorts of things happening smoothly. You arriving here, you getting coffee, you getting something to eat, all the stuff working, and it's certainly not me. I mean, if anything, she would say I'm probably the hindrance. And that's Jenny Lee Cardy. I'd just like to thank her very much. Thank you all very much. Hopefully in the future we will continue to have these conversations and work together. Please join us for lunch.